So let's solve the question once again. It's involving the neurology, I guess. So whenever in the last session, I think we missed a lot of things. We will try to cover all of this fact in this session. Okay, so a 20 years old man present for evaluation of the weakness of his face and upper extremities, which gradually progressive over the first few years. The patient has a nearly expressionless face. That is very important. So whenever we think about the expressionless face, there is a possibility of thinking of the Parkinson's, right? There is some difficulty in closing the eyes tightly and pursing his lips. So closing the eye tightly, and there is also pursing his lips as well. So there will be some asymmetrical upper extremity weakness, also difficulty lifting the arms above the head. So there is a humeral weakness, right? I guess it could be a possibility. Upper arm weakness, that is a good possibility. Also, there is expressionless face and difficulty in closing eyes. So there could be a facial nerve involvement as well. Okay. So there is some weakness of foot dorsiflexion also. There is muscle atrophy, more prominent in the upper extremity, also weakening of the scapula. Interestingly, the upper arm seems to be a bit thinning in the forearm as well. Okay, so deltoid is relatively spare. This is the Popeye the Sailor Man. There is a cartoon as we seen from the Young Cartoon Network, which used to see in a long period of time. Okay, so there's a Popeye the Sailor Man. Whenever we look about the Popeye the Sailor Man, there is proximal muscle, particularly involving the upper arm, is wasted, and there will be extensive hypertrophy of the forearm. I guess that is the typical body build of Popeye. Okay, so there's Popeye the Sailor Man types of appearance, and the patient having the creatinine kinase of 510, so it's a bit elevated. But which muscular dystrophy the patient is having? So when you are thinking of the muscular dystrophy, there's two types, Duchenne and Becker's muscular dystrophy. Whenever we are thinking about Duchenne muscular dystrophy, this at the age of 20, the patient will be already dead or will be wheelchair bound. Absolutely. Okay. He or she will be, particularly he, will be having some troublesome, muscle weakness with pseudo hypertrophy, with difficulty at walking at this period of time. Also having typically wheelchair bound. Also, he might be having increased amount of creatine kinase, recipe problem with cardiomyopathy. So particularly Duchenne is not that much common, will not present like this in this moment, in this period of time. Second thing, whether it could be Becker's. Becker's could have initial manifestation in the later aspect of time. Patient will be wheelchair bound after the 20s, 30s, or something like later condition, more likely. So Becker's is not having any particular predilection to the upper limb, particularly the upper part of the arm. It's not that much common predilection. Also not commonly involve the facial muscle exclusively. So the issue is that there is a facial involvement. Also there is scapular involvement, I guess. Upper arm involvement is there. Okay, we should think about facioscapulohumeral dystrophy. Okay, facioscapulohumeral dystrophy can present like this. It can involve the face. It can involve the upper limb. Also sometimes there could be some problem with the dorsiflexion also. Okay, so that is also very important. The dorsiflexion problem could be an issue in the facioscapular also. When you're thinking about the Emily-Dreyfus muscular dystrophy, you should think about three conditions. First, there will be contracture. There will be a lot of contracture. There will be cardiac conduction defect, and there will be scapulohumeral peroneal atrophy. Okay, so there will be scapular problem, there will be humeral problem, there will be peroneal problem as well. Okay, so the issue is that there is relatively there is the peroneal issue is not involved that much. Okay, so there is the face and shoulder and lower extremity involvement. It is asymmetrical presentation with typically relative sparing of the deltoid. So I get more in favor of facioscapular muscular dystrophy. Okay, so let's check the answer. Okay, it's a facioscapulohumeral dystrophy. I guess it is an autosomal dominant disorder. Particularly, we should remember the fact there is some repeat sequences also in D4J4. We should remember the D4J4 particularly involvement. It's an autosomal dominant condition. Okay, facioscapulohumeral dystrophy, it's a progressive condition, involve the face and shoulder particularly, but later course of the disease there will be lower extremity involvement as well. Particularly, the age of onset is 16 in case of male, 20 in case of female, but it can be variable definitely. The issue is that the weakness is asymmetrical. Typically, having some weakness in the arms. Okay. Also, there is some facial muscle involvement. In case of upper limb, there is scapular muscle, biceps, triceps, trapezius, serratus anterior, and pectoris involvement with, very important, there will be relative sparing of the deltoid. Another thing we should remember regarding that, in monomanic amyotrophy or Hirayama disease, there will be relative sparing of the brachioradialis. Okay. So in the upper limb seems to be a bit more atrophied in comparison to the forearm, making the bones of the shoulder more prominent. Also, there is a facial weakness, that there will be weakness in the orbicularis oculi, there will be weakness in the zygomatus, there will be weakness in the orbicularis oris also. Okay. Sometimes in the abdomen, there is a sign that is called the Bivor's sign. Okay. Sometimes, whenever the neck is flexed due to weakness in the lower abdominal muscle, umbilicus will be difficulty to, there will be some positional difficulty. As there is some lower muscle weakness, lower abdominal muscle weakness, whenever we try to, flex our neck, the umbilicus, it tends to be get elevated. Okay, the position should be changed. The umbilicus, is seeming like it's going upward. Okay, so that is typically called the Bivor's sign. Sometimes, there could be some weakness in the dorsiflexion with preservation of the plantar flexion is typically characteristics for, facial scapulohumeral dystrophy. So, as I told earlier, there is particularly the temporalis, the masseter, the extraocular muscle, the phalangeal and respi muscle is typically spared. The temporalis masseter will be more wasted in case of myotonic dystrophy. The extraocular and phalangeal muscle will be more wasted in oculopharyngeal muscular dystrophy. So these two will be myotonic dystrophy. These two will be oculopharyngeal muscular dystrophy. Okay. So the cardiac involvement is quite rare. Intelligence is also normal. Cardiac involvement is common in hemorrhagic muscular dystrophy. Okay. So we are going to the next question, I guess. So a 52-year-old man, originally from the Montreal clinic, with presence with progressive dysphagia, dysphonia, and bilateral ptosis. Okay, there is no fatigability. Besides the ptosis and evidence of dysphonia, rest of the neurological examination is absolutely unremarkable. So that is very important. Okay, so rest neurological examination having no issues here. And apart from there is, as we get the ptosis, we performed a tensilon test that is absolutely normal. The acetylcholine receptor antibody is negative. MRI didn't show any abnormality. Which muscular dystrophy will be more likely in this condition? So it's not Becker's, it's not myotonic, it's definitely not facioscapulohumeral, I've told earlier. So considering there is some bilateral ptosis with some difficulty in swallowing. Okay, so there's a pharyngeal weakness, there is some ocular weakness. So it's most likely oculopharyngeal muscular dystrophy. The patient is having the oculopharyngeal muscular dystrophy. This is the autosomal dominant condition of late onset muscular dystrophy. The presentation is typically restricted to oral and pharyngeal lesion. So that is very important. We should remember the patient is having, the oculopharyngeal muscular dystrophy. The issue is typically involving the oral and pharyngeal regions as well. Okay, so sometimes it is more common in a French Canadian descent and particularly associated with GCG, repeat expansion in chromosome 14. Okay, so it's also repeat expansion disorder. We should remember GCG. Okay, sometimes there could be involvement of PABPN1 also. Another thing we should remember, there is no genetic anticipation in this case. Okay, in spite of being a GCG is difficult for me to, so it's a difficult, sometimes it is a repeat mutation in spite of having a repeat mutation, it is not showing any genetic anticipation, because most of the tiny nucleotide repeat disorder having typical predilection and having genetic anticipation like Huntington or like, Fragile X syndrome. Okay. So the patient is, there will be some rim vacuoles as well. Whenever we are checking the biopsy, there will be some, variation in the fiber size. There are some rim vacuoles as well. There could be intranuclear tubular filament on biopsy also. The rim vacuole is typically found in another condition, that is the inclusion body myositis. Okay. Now, so muscle biopsy demonstrate typically there will be variation of fiber size, rim vacuoles, I have told earlier. And in case when I'm talking about the creatine kinase and aldolase level is typically normal in this condition, and sometimes the EMG level is abnormal. So we should remember about the CK level. There is not that much increased. The EMG is abnormal when we are thinking about the what are the affected muscle. Okay, on the affected muscle, the EMG must be abnormal. Okay, and the patient having dysphagia, dysphonia with ptosis. Whenever we got a patient with ptosis, facial nerve involvement, we should think about myotonic dystrophy also, but there is no features of myotonia in this scenario. So now, what will be the characterization in this condition? A mutation in the dystrophin gene, is it true? I'm not thinking that as well. Whether it is, X-linked recessive inheritance, I guess it is not that much of X-linked recessive. It is more in favor of, I guess, autosomal dominant most likely. So the variation in the fiber size, rim vacuole, internuclear tubular filament, is a typical, goes by. So it is most likely the answer. There should not be any myotonia. CK is typically normal in this scenario. Okay, so that will be the answer. Variation of their fiber size, there will be limb vacuoles and internuclear tubular filament whenever we are thinking about a biopsy. So it is autosomal dominant. As I told earlier, this is autosomal dominant. Facioscapulohumeral is also autosomal dominant. So in comparison to Duchenne-Beckers, which is X-linked recessive. Okay, so these are the autosomal dominant condition. Having late onset muscular dystrophy, typically restricted to oral and pharyngeal regions. We should remember there is a certain involvement in the French Canadian descent caused by the GCG repeat expansion in chromosome 14. The patient will be having dysphagia, dysphonia with ptosis, some extrapolar muscle involvement as well, but there shouldn't be any myotonia at least. Okay. Another thing is that sometimes, there could be creatine kinase and aldolase level is typically elevated. But the issue is that whenever we do a muscle biopsy, we'll get a variation in the fiber site. There will be rimmed vacuole and there will be internuclear tubular filament. So these are the facts we should remember. Okay. Yes. Not actually. Whenever we think about the rimmed vacuole in inclusion body myositis, there will be other features of inclusion body myositis as well. Particularly, there will be weakness in the finger flexor or quadriceps weakness. These are the factors we should also remember. Yes. Now the next question. Yeah. So a 25 years old man was referred from an infertility clinic. So there is some infertility ongoing. So we are thinking about the infertility with muscle weakness. He was having the frontal balding, atrophy of the temporalis masseter. So I guess it's we have already got the diagnosis by only this feature also. The patient having infertility, so there could be testicular involvement as well, having frontal balding, temporalis masseter. Okay, there's some weakness of the sternocleidomastoid bilateral ptosis. It is typical scenario of myotonic dystrophy. So what we are thinking about that whether it is proximal myotonic dystrophy or distal myotonic dystrophy. So whenever, as you can see, the weakness, there is upper extremity weakness, especially the forearm extensor as well as anterotibial, also weakness in the dorsiflexion of the feet. So there is some distal predilection. Okay, after percussion of thenar, there is prolonged contraction among sole relaxation, and this is typical of distal. So myotonic dystrophy type 1 will be the best possible answer. So the patient is having dystrophica myotonia type 1. That is the problem. It is an autosomal dominant condition like the previous two, oculopharyngeal and facioscapular. So it is a trinucleotide repeat disorder with high penetrance, particularly the CTG in chromosome 19. Where the patient typically presents in the adult life, patient having ptosis, having facial weakness. So ptosis more in common in patient with oculopharyngeal, facial weakness in facioscapulohumeral dystrophy. But the issue is that there will be frontal blinding, atrophy of the masseter temporalis, weakness in the atrophy of the muscle of the hands, and particularly extensor of the forearms and peroneal muscle as well. So hand muscle with a lot of involvement. In case of distal muscle, type 1 distal muscle will be important. That will be involved more. Okay. Alongside, there could be pharyngeal and laryngeal muscular weakness also. The patient have myotonia, which is a phenomenon of prolonged contraction and slow relaxation. Patient might be having any diaphragmatic weakness as well, which may lead to respiratory failure. Also having cardiac abnormality, particularly conduction defect. We should remember this fact as well. The patient might be having any diaphragmatic weakness, which may lead to respiratory failure and cardiac abnormality. These are very common in case of myotonia dystrophica type 1. Okay, so cardiac conduction defect presents a lot of variety of myopathy, but we should remember some condition like Emery-Dufus, the myotonic dystrophy. It is one of the condition, myotonic dystrophy, when it is difficult to wean from the ventilator. Sometimes whenever we do the big surgery to a patient, at the time of surgery, we got some arrhythmia, we got some conduction defect. They might provoke us to think about whether the patient is having myotonic dystrophy or not. Okay, so there's some OT diagnosis and that whenever we are thinking about the myotonic dystrophy. So sometimes the patient might be having diaphragmatic weakness, having respiratory failure, and there is conduction defect as well. Okay, sometimes there could be some dysphagia also. The patient particularly involving the esophageal dilatation, the megacolon, there's some cataract as well. The patient might be having some developmental delay, testicular atrophy, infertility, also sometimes central and peripheral obstructive sleep apnea, right? So we should remember this fact also. So if you want to do a EMG, there will be there will be some myotonic discharges, particularly with fibrillation, and particularly whenever we do a histopathological examination, there is type 1 fiber atrophy. This is very important. So there is type 1 fiber atrophy, particularly on the histopathological examination. Whenever we're giving the steroid to the patient, the more atrophy will be more common in case of type 2 fiber atrophy. Now, a big question in the I guess it is lucky 13. So a 44 years old, otherwise healthy man brought to emergency department with the episode of loss of consciousness. So there's some loss of consciousness. He had dressed up to go to niece wedding and felt that is uncomfortable with the suit and die. Okay, he usually wears a farming clothes, did not like to be formal, felt his tie was very tight. Okay, so there is some problem in the carotid sinus, whether we should think about this condition if we are not solving a question of neurology, right? Okay, he was leaving his house to head to the wedding when his wife called him from the kitchen. He turned and said and around to see that what she wanted, suddenly without warning lost consciousness on again. Okay, so his wife called emergency medical services, and when they arrived, the pulse was only 40. The systolic BP was 88. On arrival to emergency department 20 minutes later, the vital signs and physical examination were absolutely normal. So what will be the most likely possibilities in this scenario? So it shouldn't be the vasovagal syncope. There's no long time, particularly the no long time, standing or something like that. It's not a hot temperature, not a heavy meal after asphyxia. Okay, not explain everything. Carotid sinus hypersensitivity, postural hypertension. I guess it is carotid sinus hypersensitivity. There is without any doubt. So the patient might be having carotid sinus hypersensitivity as suggested by triggering the head movement and or a tight collar. Sometimes everybody has carotid sinus in the neck, so sometimes there could be hypersensitive sinus. Whenever the carotid sinus hypersensitivity, there could be associated syncope, might be having some asystole as well. There could be fall of systolic blood pressure in response to the pressure of the carotid sinus. Okay, in the other form of carotid sinus hypersensitivity, there could be hypotension without bradycardia. So typical trigger will be a tight collar whenever rapidly turning the head, even swallowing sometimes. This is pretty much miserable, I guess. And sometimes there could be symptoms and changes in the heart rate, and blood pressure can be produced with carotid sinus massage also. Okay, the treatment typically, we should avoid the triggers, particularly avoiding the high, particularly very tight collar. Okay, whatever the clerk wire in case of the particularly the Christianity, there are a lot of clerks, they are wearing tight collar in the neck, so there could be a possibility. Whenever a patient having carotid sinus hypersensitive, we should avoid these triggers. Okay, in the otherwise it will be normal. You can use the tight wire, but whenever for everybody, very tight collar is very difficult. Okay, it can cause the carotid sinus hypersensitive. Sometimes when recurrent, patient will be developing the increased possibility of asystole. They can cause sudden cardiac arrest and death. So there could be pacemaker. They are very useful. So carotid sinus, they are typically located in the bifurcation of the common carotid artery. They are, this is the baroreceptor as well. So there could be some, glossopharyngeal branches, particularly whenever the carotid sinus receptor are stretches, the glossopharyngeal activates. This is the parasympathetic nerve. So they will come, increase the amount of parasympathetic supply. So there will be bradycardia and hypotension as well. Okay. So the issue is that this is typically leads to, particularly the low BP. Okay, whenever our BP is elevated, this is a very beneficial response actually. Whenever our BP is elevated, there is some increased stretching in the carotid sinus. So the carotid sinus will be, expand. It will, increases like a balloon. Okay, it will expand like a balloon. So whenever it will be expands like a balloon, the nerve ending that is attached to it, they will get some, irritation. They will activate it. So in that condition, it is very much easier to, put lower blood pressure and pulse rate. Okay. So vasovagal syncope, this is another important possibility. The orthostatic hypotension, whenever we try to stand up from a sitting position, if there is particularly the adrenal glands is not working, or there will be low amount of fluid in the circulation or blood in the circulation, the patient be having some troubles. Okay, some disease spells, also funny terms could be there. So it is also postural hypotension. Now the next question, this is a very important question. A 10-year-old boy has bought for the evaluation for muscle cramps, which he developed after exercise, which will be associated with limb weakness. Okay, he can resume activity after the period of rest as well. So as you can see, it is after exercise. Okay, after exercise associated with limb weakness. After exercise, he can resume the activity after a period of rest. Okay. Whenever during the leg cramps, a needle EMG is inserted in the muscle, it is electrically silent. Muscle biopsy shows absence myophosphorylis. Okay, so this is a very peculiar condition. Patient is having exercise-induced weakness, resume activity up to the period of rest. Okay, so there's a lot of condition having a particular myopathy involvement. So these are particularly the glycogen storage disease. So whenever we are thinking about the glycogen storage disease, we need to remember a lot of facts as well. They are typically involving a lot of part of the glycogen. It's a big part, I guess. So whenever we're thinking about the lysosomal storage disease, we should remember some facts as well. Particularly, there is a lot of condition, but some condition we should remember. This is the type 1, this is type 2, this is type 3, this is type 4, type 5, type 6, and type 7. Okay, I'm not going to go further because I don't know further. So the first episode, this is typically the von Jart's disease. Okay, so von Jart's is the first possibility. Second possibility, whenever we think it's a Pompe's disease. Whenever you're thinking about the third disease, that is the Cory's disease. Sorry, I just changed the mouse pad for a better writing, I guess. It's causing some problem. So the first possibility is von Jart's, second possibility is Pompe's, third possibility is Cory's disease. Whenever thinking of the fourth possibility, that is a typical Anderson disease. We should remember it is very important, Anderson's disease. Whenever think about the fifth disease, that is the typical McArdle's, which we should remember. This is a very important disorder of the muscle. And then number 6, there is Hart's disease. And last but not the least, Tardieu's disease. Okay, so how we should remember this factor as well. Whenever we think about the von Jart's, okay, there's von, so there could be on. Okay, so von, there could be on. Okay, whenever we think about the 2, so I guess there is 2 TWO. Okay, there's POMS. We just altered the W, so there's POM, so it could be Pompous disease. Okay, there is CORI. There is CORI. So whenever you think about the CORI, there could be a possibility of having the third condition as well. Okay. Whenever thinking about the, particularly the Cory's disease, it is the third condition. Okay. Anderson is 4, McArdle's is 5, Hart's is 6, and Tarus is 7. So these are the 7 possibilities. Whenever these are the all problems of the glycogen storage disease. Okay. So whenever we're thinking about it is the exercise induced problem, we should think about it is whether it is glycogen phosphorylase problem or not. Okay, so glycogen phosphorylase can present in 2 aspects. First off, in the muscle, and whenever it is also could be in the hearts. Okay, that is hepatic. So whenever we think in the muscle disease, the McArdle's, there should be any muscle cramps and hypoglycemia with myoglobinuria whenever one try to exercise. Okay, so there could be a good possibility of having the exercise induced weakness. We should think about McArdle's. It's a very important disorder. So it is the typical McArdle's disease. This is the glycogen storage disease type 5. It is the problem in the phosphorylase deficiency, particularly the muscle phosphorylase. So whenever it is an autosomal recessive disorder of the myophosphorylase, whenever one try to exercise, whenever one try to act or any activity, particularly, there is some muscle injury. Why there will be muscle injury? As there is deficiency in the glycogen myophosphorylase. So glycogen will not be converted into glucose 6-phosphate. Whenever it is not be able to convert it into glucose 6-phosphate, there will not be any glucose. Okay, so that may leads to glycogen accumulation in the muscle, and they may induce muscle cramp and muscle death. Okay, so the issue is that whenever we try to insert a EMG needle in the contracted muscle, okay, whenever you should remember a fact. Okay, whenever we want to do a EMG in the contracted muscle in this respect, there will be electrically silent. Okay, this forms the basis of the definition of the true physiologic muscle contraction in contrast to chronic shortening of a muscle or tendon, which is strictly speaking a pseudo contraction. Unlike the normal muscle, whenever the muscle will exercise, there will not be any production of any lactic acid. So the issue is that there is deficiency in the myophosphorylase. So there will be exercise-induced muscle damage. There will be release of myoglobin. So these are common conditions. Another thing we should remember, the second wind phenomenon. What is second wind phenomenon? Whenever a patient having some myophosphorylase deficiency, whenever he or she will starting the exercising, he's having some muscle cramp with myoglobin. After some period of time, there could be restoration, and the patient might be able to do the exercise or activity as well. So this is typically called the second wind phenomenon. The second wind phenomenon is typically present and typically seen in the case of McArdle's disease, okay, which results from typical mobilization of the blood glucose. Now, there is some other condition as well. Number 1, the Tarus disease. As I told earlier, there is the phosphofructokinase deficiency. Whenever we're thinking about the Tarus disease, in this condition, there will be deficiency of the phosphofructokinase. Okay, so that will be the deficiency present in the muscle and present in the RBC also. So in this condition, the patient will be developing, there is some RBC problem. Okay, so a lot of activity of phosphofructokinase in the RBC not ongoing. So there could be some hemolysis. The patient will be having some hemolytic anemia, and whenever it is a lot of RBC will be destroyed. So there will be some nucleic acid damage as well. So there could be some gouty arthritis. Okay, so gouty arthritis. So there could be some uric acid accumulation as well. So patient will be having some jaundice that is due to hemolysis, and also gouty arthritis, in particularly Tarus disease. So jaundice, gouty arthritis, should think about Tarus disease, right? So Heart's disease, another possibility. Heart's disease, it is hepatic phosphorylase deficiency. So whenever we think about glycogen phosphorylase absence in hepatic region, the patient will not be forming any sorts of glucose. Okay, because the issue of hepatic glycogen will be changes into glucose that will be due to glycogen phosphorylates. So glycogen phosphorylates in the liver is not working, so the patient is not having any glucose as well. Okay, so the issue, there will be the more hypoglycemia in the fasting condition, because in the fasting condition the liver takes upper hand. So liver is not working, so will not be able to take any upper hand. Fasting hypoglycemia, that is the important criteria of having any heart disease. Second important thing is that there will be hepatomegaly, as there will be glycogen accumulated. Why there will be glycogen accumulated? There will be some long changes, branching. There are some issues that glycogen should be branches to, there should be lessened. Okay, they should be degraded, they should have a normal structure. So in this condition, glycogen will not be normal, they will tend to accumulate in the liver, so we'll get hepatomegaly. So we have discussed three conditions. First, at Tarus disease, Hart's disease, and von Jart's disease. Okay, so another important thing is that two things is we should also remember the Cori disease and Anderson disease. Cori disease and Anderson disease. Okay, so whenever we got some glycogen, okay, the issue is that whenever we are thinking about the glycogen storage disease, the glycogen must be converted to glucose whenever necessary. That is the issue there. That glycogen is not typically converting properly. Okay, so there's some enzymes, role of enzymes can have a role regarding the conversion of glycogen. Okay, some enzymes, particularly the branching enzyme, some enzymes they involve the debranching enzyme as well. So whenever there is some issues in the branching enzyme ongoing, the patient might be having Anderson disease. When there will be issues regarding the debranching enzyme, the patient could be having Cory's disease. It's so easy to remember, as Anderson has A, then branching enzyme. So A, B. Cory has C, so there could be debranching enzyme. C, D. So A, B, C, D is very easy to remember, right? So whenever you're thinking about, there will be some issues in the branching enzyme. So in that condition, in normal condition, the glycogen is branches to non-toxic substance by the means of branching enzyme. Okay, so whenever we are getting this, debranching and the branching enzyme problem, there in that condition, the glycogen is not able to be branched. It will tends to become a long chain. Okay, so whenever this is suppose a glycogen, whenever we are converted into a branching enzyme, this is like these sorts of glycogen will form. This will be the branch of the glycogen, right? So whenever the branching enzyme is not there, the glycogen is like this, it is grow horizontally to a lot of chain, right? There will not be any branching. This long chain glycogen will tend to accumulate in the liver, particularly due to absence of this branching enzyme. So it will having particularly this long chain. It is very toxic. They can cause the liver damage. The patient will develop the cirrhosis, even liver failure also. Okay, so Anderson's having the problem of B, branching disease, causing the problem of glycogen accumulation, long chain glycogen in the liver, causing the CLD, the C. So A, B, C. What is A? Anderson's deficiency in the branching enzyme. C, patient will be developed cirrhosis of the liver. Okay, so this is Anderson. Now the Cori. In case of Cory's disease, there will be a problem in the debranching enzyme. So debranching enzyme, the issue is that it will, the enzyme, particularly 1-alpha-6 glucosidase, it is helps to, recovery of the glucose. So there will be in Cory's disease, there will be, difficulty in formation of glucose. So glucose will be lessened, patient having typical hypoglycemia. Okay. And the first two conditions, the first condition will be the patient having von Jart's disease. In that condition, glucose, whenever we try to, form glucose, we should form it from the glucose 6-phosphate. Okay. That is whenever we try to, implement glucose in our body, we need glucose. Then in that condition, the first step will be from glucose 6-phosphate to formation of glucose. Okay, whenever we try to form glucose from the glucose 6-phosphate, we need a typical enzyme called glucose 6-phosphatase. As there is a deficiency in the glucose 6-phosphatase, glucose won't be there. So there will be patient will be having a severe hypoglycemia. There will be increased accumulation of glycogen in the liver, kidney. Okay, so the liver, kidney will accumulate the glycogen and glucose is not there, and the patient will develop severe fasting hypoglycemia. Okay, this is typical von Jart's. Another thing is that at glucose is not occurring, so patient will try to use more lactate. okay, more triglyceride or uric acid for the energy. So the patient, increased amount of lactate is ongoing because the lactate will be the source of energy, and this lactate will become from the increased amount of triglyceride, increased amount of uric acid. So these things will be accumulated. This is typical Vonter's disease. Okay. So I guess we have a discussion corresponding to that. And now the core disease, as I told earlier, the deficiency in the debranching enzyme, there will be accumulation of the glycogen. Okay, so the issue is that there's the issue is the debranching enzyme. So there's accumulation of glycogen. The patient might be having some, hypoglycemia also. Also, there could be some problem, muscle problem as well. In Anderson's, there is a glycogen branching problem. The patient will be ultimately developing CLD and liver failure. Or Pompe's disease is the acid maltase deficiency. It is the problem of the glycogenosis type 2. In that condition, there will be cardiomyopathy. Now, the next question. A 66-year-old man presented to emergency department with complaining 2 weeks history of the marked slurred speech. So there is slurring of speech, there is a solemn difficulty, there is trouble holding the head up, okay? Diagnosed with myasthenia gravis 2 years earlier. The symptoms only induce diplopia, and there is a flu-like illness 2 weeks earlier. On examination, he has bilateral ptosis, severe dysarthria, cannot hold his head up. Okay. Also is complaining tachypnea, also using accessory muscle for breathe. The negative inspiratory force is minus 15 centimeter water pressure. What will be more appropriate management? As you can clearly see, this is not a typical myasthenia. This is now myasthenic crisis. Okay, whenever you think about the myasthenic crisis, as the patient having the dyspnea, the patient having your accessory muscle to breathe, having negative inspiratory pressure of minus 15. Okay, so the treatment will be dependent upon particularly emergency basis. So first, we should check the option. The provide with the prescription of pyridostigmine. Patient taking medication, not really. Administer intravenous methylprednisolone while he is in the emergency department. Admit the hospital and frequent checks of respiratory function, FVC. It's a good option. Admit to the ICU, intubate, initiate therapy with intravenous immunoglobulin and plasma exchange. Admit for immediate thymectomy. So all of them are very good option, but particularly we should remember whenever we got a patient having negative inspiratory force is particularly less than minus 15. Okay, or whenever we got a patient of force vital capacity of I guess it's 15 also. So negative inspiratory force of minus 30, less than minus 30, or the forced vital capacity of less than 15, we should give the patient an intubation ventilation. So I guess we should admit him. First of all, we should intubate and ventilate, then try for the intravenous immunoglobulin or plasma exchange. So the patient depicted in picture 15, having presented with myasthenic crisis, has respiratory involvement, negative inspiratory force, and force vital capacity should be monitored closely. Okay, intubation ventilation is the absolute best response whenever we getting a myasthenic patient who have particularly the inspiratory force of less than minus 30, or having the FVC of less than 15, or there is significant downward trend of inspiratory measures in clinical evidence of respiratory muscle fatigue. Okay, we should admit the patient to ICU. We should get him or her intubated and mechanically ventilated. That is the most important function as well. However, in normal cases, we should give the pyridostigmine or any other possibility. We should follow up the patient, okay? Or if the patient is having stable condition, like the FVC is stable, it's greater than 15, or having the fourth inspiratory negative inspiratory force is less than greater than minus 30. In that condition, we should give the patient steroid or other drugs as well, but should not be intubated, ventilated. If this condition occur, the first statement will be intubated, ventilated. The steroid or plasmapheresis or IVIGT should come later. Okay. So the patient should be admitted into ICU, intubated and ventilated, and other management. There could be initial treatment with other management, particularly IVIGT or plasmapheresis. So both of them are reasonable option. The superiority trial has not been established still, so we should remember the fact as well. Okay, these are the facts, very important. Okay, so medication that can exacerbate myasthenia gravis, it's a very high yield option, high yield thing that we should remember. What are the medication? They are particularly, sorry, they are particularly the aminoglycoside. We should remember the fact the aminoglycoside can involve, the patient might be having the beta blocker. Actually the antibiotic, there is several antibiotic particularly. First of all, we should remember about not only the aminoglycoside, okay, apart from aminoglycoside, we should remember about quinolones, particularly Cipro. We should remember about Tetra. This group is also very high yield. We should remember about macrolides also, right? So these are the actually the medication which it also should remember. So these medication typically exacerbate the myasthenia gravis. So these are the medication we should avoid or should give in a lowest possible dose in particularly in myasthenia gravis, right? And particularly another thing is the beta blocker, the neuromuscular blocking agent, even magnesium. Okay, whenever a patient having eclampsia, let's talk about the scenario. Patient is having eclampsia, having a convulsion, also having a known history of neuromuscular junction disorder that particularly involve the myasthenia gravis. What medication we shouldn't give? We shouldn't give the magnesium, because magnesium, it's also neuromuscular blocking agent. You should remember. Okay. So this medication should be avoided and used in the lowest possible dose in a patient of myasthenia gravis. So also the penicillamine, sometimes they can cause the seropositive myasthenic syndrome. Okay. Some majority of the patient of myasthenia gravis, except particularly some have pure ocular variety, they require the immunosuppressive therapy. Okay. Sometimes we can treat the patient having corticosteroid, also secondary immunosuppressive therapy that will involve the azathioprine or mycophenolate mofetil. Even sometimes other drugs could be involved as well. Okay. Now, caution regarding the initiation of steroid therapy. Whenever the symptoms are severe, okay, there is significant respi and pharyngeal muscle involvement. Okay, so particularly we should give the patient plasmapheresis or IVIG because the patient having severe respiratory problem or severe muscle problem, we should start plasma exchange or plasma IVIG in comparison to prior to steroid. Because whatever is starting steroid in the first place, the patient might be having some deterioration of the symptom as well. In secondary condition, azathioprine, mycophenolate mofetil, cyclosporine, they can be useful. Okay, they might be having reduced possibility of having steroid in the longest possible of time. Whatever thinking about the pyridostigmine can have symptomatic benefit, but will not alter the course of disease in this scenario. In the majority of patients of autoimmune myasthenia gravis, thymic abnormality is present. Particularly, there is thymic hyperplasia. In case of 10% cases, there is thymoma. Thymoma can be benign. Even thymoma can be malignant also, right? So in that case, the resection of thymus, regardless of whether thymoma present or not, can induce a potential remission in a case of myasthenia gravis. Okay, in autoimmune myasthenia gravis, there is an ongoing trial to determine the utility of thymectomy. Okay, so, however, there is evidence that patients who undergoes thymectomy are more likely to attain remission from their myasthenia gravis. So, therefore, the issue is that what we should remember, thymectomy is recommended in all patients of myasthenia gravis whenever the age is less than 60. Particularly, the young woman shown to be a very great benefit. Okay. So, that is the thymectomy is generalized myasthenia gravis. Thymectomy recommended particularly in all of the patients. The most likely the patient will be particularly having the acetylcholine receptor antibody positivity. So the response to resection should not be evident overnight. It will take some times because myasthenic symptom can worsen in the post-perioperative period. So the stabilization symptom, and sometimes you should give the patient the IVIG, G or plasma exchange prior to operation is very much helpful to reduce the risk of OT complications. Now, the next question. Aminoglycoside beta blocker should be avoided as they can exacerbate it. Absolutely correct. Thymoma, it's not true. We can give a lot of patient who is having general myasthenia gravis, particularly having the AS less than 60. We should do thymectomy. The pyridostigmine provide a symptomatic benefit and modifies the long-term course of disease. Okay, yes, it can provide symptomatic benefit, but do not modify the long-term course of disease. Corticosteroid, of course, it can cause transient worsening of the symptom. Long-time immunosuppressive therapy, azathioprine and mycophenolate mofetil, is of course recommended. So A will be the answer, as I told earlier. Let's have this information again. Thymectomy is recommended in patient with myasthenia gravis whose symptom onset prior to 60. Okay, and the young woman seems to be show a very great response. Now, a 8-year-old boy presents for evaluation of the stiffness and having difficulty in relaxing his muscle. So there is some issues of stiffness and so also having some problem in difficulty in relaxing his muscle. He has some difficulty in opening his eyes and opening eyes after closure. So also difficulty in releasing after, grasping with his hands. Okay, so these symptoms are worsening after exercise and after performing the same task multiple times whenever exposed to cold. His father also has similar types of symptoms as well. So I guess it's typical myotonia. So what is the possibility? That is the thing we should remember. So first of all, the condition, hyperkalemic or hypokalemic periodic paralysis should not present with myotonia. So the hyperkalemic periodic paralysis, typically we exclude by this history, right? So this exclude. This should not present with myotonia. There is 3 possibility. First, myotonia congenita, that is divided into 2 types. First, Thomson disease and Becker's disease. Second thing is that whether it could be paramyotonia congenita. Firstly, we'll think about the myotonia congenita. Myotonia congenita is of 2 types. First of all, whether it could be autosomal dominant. It is the Thomson disease. The patient having young presentation with a bit, the patient will be stable, not that much severe. Okay, there will be some features of the myotonia. The issue is here is the chloride channel involvement. Okay, so the chloride channel involvement will be there, but issue is that there will be not that much severe myotonia. Okay, the patient will improve in the long run. Okay, will stable in the long run, not that much improve, but will stable in the long run. And the Becker's muscular, this is the autosomal recessive. In comparison to Thomson, the patient will not be improved and will tend to deteriorate in the long run. Okay, the issue is that the Becker's present later, but having very better. But I want to say that it's a very difficult prognosis. So it's so bad prognosis, right? So whenever you think about the myotonia congenita, you should remember that the patient having initial myotonia, but whenever we try to exercise, whenever we try to do the job, it tends to get improved after a period of time. This is the warm-up phenomenon. So warm-up phenomenon typically seen in the myotonia congenita. On the other hand, on paramyotonia congenita, patient having autosomal dominant, the exercise or cold having worsening of the symptoms, but the patient will not improve whenever he or she will try to have these repetitions. Okay, so there will be some deterioration of the symptom in the long run, the typical for paramyotonia congenita. So I guess paramyotonia congenita could be the most possible answer. The patient having autosomal dominant channelopathy involving the SCN4A. There is other condition that involving the SCN4A also. They involve the hyperkalemic periodic paralysis or also type 2 hypokalemic periodic paralysis. They tends to involve the sodium channel 4A, right? The issue is that here the manifestation is similar to myotonia congenita, but unlikely there is no warm-up phenomenon which is present in the myotonia congenita. Rather, in this condition, the repeated exercise accentuate the myotonia, which is typically and clearly appreciated more in the eyelid. Okay, this thing very important. I'm marking this as well. So here's the names. It is derived from the paramyotonia. It's actually paradoxical response to the exercise. Okay. In myotonia, there will be no paradoxical response. And in paramyotonia, there will be paradoxical response. So exposure to cold, worsening the myotonia, precipitate the weakness, also in contrast to myotonia congenita. Okay. Percussion myotonia can be rare. Whenever exposed to cold, there could be percussion myotonia. EMG after cold exposure can demonstrate the fibrillation potential. Okay. Now, the next question. As you can see, a 32 years old woman presents for a blood draw as a part of the pre-employment health evaluation. He starts to feel lightheadedness, having some, sweating profusely, lost consciousness, and lies listless on the floor. There is no convulsive activity, no loss of bowel or bladder control. Approximately 15 minutes later, she regains consciousness. She feels slightly lightheaded, but is not confused at all, is able to recall all the events preceding her loss of consciousness. Okay. So it's not seizure at least, right? A few minutes later, she's feeling absolutely fine. So what is the most likely diagnosis in this patient? Okay. So first, whether it could be vasovagal syncope, it could be glossopharyngeal neuralgia, it could be seizure, it could be carotid sinus hypersensitivity, whether it could be third ventricular mass. So this is not a severe condition. I guess it's a simple condition. Patient having this problem with profusely sweating, lightheaded, and consciousness with rapid recovery goes more favor in vasovagal syncope. Okay, so whenever thinking vasovagal syncope, it is actually neurocardiogenic syndrome. In this condition, in these sorts of syncope, there will be transient loss of conscious. There are several causes. It could be a potential trigger, and important trigger that we should forget in some spaces, that's a phlebotomy. Sometimes phlebotomy is an important cause of vasovagal syncope as well. Okay. So the clinical features such as vasovagal syncope include the preceding, the concomitant diaphoresis, palpitation, or that is more common in the female as well. Some other options is a potential cause of syncope, particularly the glossopharyngeal neuralgia. There will be some severe pain in the glossopharyngeal distribution, like the pain will be in the hypopharynx, pharynx, also involved in the tongue, ear. It's a repetitive pain. And as there is glossopharyngeal involvement, there should be some sorts of vagal involvement also. The patient might be having hypotension with bradycardia. That might be associated with these sorts of syncope. Also, there could be cardiac asystole as well. So it's very important. So in this condition, there is no feature to suggest the glossopharyngeal neuralgia. The lack of postictal confusion and absence of convulsion help to distinguish syncope from seizure in this condition also. The carotid sinus hypersensitivity, this is, as I told earlier, this is the patient in the carotid sinus, particularly tight collar. Third ventricular tumor, but colloid tumor can also have this syncope-like presentation. This is due to raised ICP. So I guess it's the situation more favor of the vasovagal syncope. So a painful question is upcoming, as we see from the muscle biopsy as well. So a 8-year-old boy has brought by his parents to see into the clinic. His motor development delayed, difficulty walking, his weakness predominantly involving the proximal muscle, also severe weakness in the hip muscle, the quadriceps, the glutei muscle, also involving the pretibial muscle as well. He also has pectoral and shoulder weakness, also having wing of the scapula, calf, his calves are enlarged and having a rubbery texture. IQ is low, CK is so much elevated, muscle biopsy, as you can see. Which one of the following is the most likely diagnosis as well? So the youngest presentation, let's see the option. Okay. As you can clearly see, it's the 8 years. The patient having severe weakness in the proximal muscle, also having a lot of muscle, the flexor, the quadriceps, the glutei, the pretibial, CK is elevated, IQ is low, age is only 8. So let's talk about the disease. First of all, there's a lot of muscle involvement involving the proximal muscle, winging of the scapula. Also, there is cuff, it's also enlarged. So it should not be any limb girdle or limb girdle subtype. So we could exclude that. There is no typical feature suggestive of amiris or facioscapular. Okay, so the issue is that it is difficult. It is between the Duchenne and Becker's. Whenever the age is 8, think of Duchenne, because Becker is a later presentation. The patient having Duchenne muscular dystrophy, it's a dystrophinopathy, not dystroglycopathy. Okay, so it's dystrophinopathy involving the X-linked recessive fashion, and most likely it's a genetic disease involves such a lower amount of case. Okay, sometimes it could be also having some spontaneous mutation as well, so there should not be any family history. Okay, and sometimes the family history is obscured in whether to arise or increases the difficulty of the scenario. Okay, so sometimes there should not be any family history. The condition presents early in the life, that is very high yield, so presents like weakness and delayed developmental milestone, hence the patient having low IQ. So patient might be having regular fall. There could be difficulty in walking, running, rising from the supine from sitting position, weakness predominantly involving the psoas muscle, that will involve the iliopsoas, the quadriceps and glutae, and also the shoulder girdle and upper limbs as well. The patient might be having the pseudo hypertrophy of the cuffs due to fibrosis. There could be scapular winging. There could be cardiac involvement as well, because there will be some arrhythmia, cardiomyopathy, and heart failure. So it is important and recommended that all patients of Duchenne can have a cardiac evaluation to exclude any features of arrhythmia or cardiomyopathy. So there could be developmental delay, low IQ. The important issue is that most of the patient will be having sometimes the wheelchair or bed bound, eventually die due to respiratory failure or having some pulmonary infections as well. So in case of Duchenne or Becker's muscular dystrophy, the CK will be elevated. The EMG shows fibrillation. Also, there could be some myopathic motor unit potential. So the patient biopsy findings indicate some endomysial fibrosis, loss of muscle fiber, residual fiber of various size. There could be eosinophilic and atrophic. Okay, degeneration and regeneration as well as necrosis can be seen. Okay, but the issue is that there is generalized myofiber necrosis, degeneration, regeneration, and variation, endomysial inflammation, and fibrosis. They are typically collectively called dystrophic chain. So what is a dystrophic chain? There is necrosis, regeneration, degeneration, first degeneration, regeneration, fiber variation, endomysial inflammation, and fibrosis. All of these things could be present. So here, there will be absent of dystrophin. So dystrophin is a cytoplasmic protein that interacts with the actin, and particularly it forms a dystroglycan complex. Okay, so the dystrophin and actin, they're very important, providing structural link in the sarcolemmal skeleton. Okay, whenever the dystrophin is lost, the sarcolemmal structure has been severely affected. The muscle will be more susceptible to damage and rupture. So the diagnosis should be checking the molecular diagnosis and absent dystrophin level on the muscle biopsy. So this is very high. There could be absent muscle biopsy. In Becker's muscular dystrophy, similar to Duchenne muscular dystrophy, which is less severe, later onset in this condition. Now, which one of the following is correct regarding this condition? All of the patient of this condition should go cardiac evaluation. This is right. The patient might be having X recessive, so B is false. Resp involvement will be there, so C is false. Family history, not that much issue. Extraocular involvement, not that much common. So I guess it's A. Now, a 21 years old man from Japan bought for evaluation of gait disturbance. He has bilateral foot drop, weakness affecting the anterior leg compartment, the mild weakness in the upper extremity, having the extensor muscle. Okay, the muscle biopsy shows rim vacuole. Electron microscopy shows a tubular filament resembling what we have seen in the inclusion body myositis. Patient parents not having any known muscle disease. So which one of the following will be the most possible answer in this condition? So there is some condition. Whenever we discuss the myopathies, particularly some congenital myopathies, we should remember about the collagenopathies. The collagenopathies involving the Ehrlich and Bethlehem. In case of Ehrlich, there will be predominant, there should be some calcaneum abnormality. Okay. So the issue is that in case of, collagenopathy, particularly the early, the muscle weakness, it is in the young age. Okay. There is contracture, there is distal hyperlaxity and protrusion of the calcaneus. Okay. So there is not that much, I guess it's a distal hyperlaxity. Okay. So another possibility is that whether it could be Marksberry gigs, whether it could be Wallander, whether it could be Nonaka, whether it could be Mayoshi. Okay. In case of Wallander, I guess it is more likely to be involved. It's an autosomal dominant condition. Okay. So the patient will be having some family history ongoing. Okay. So there could be a possibility. But in spite of that, there could be new mutation also. So the issue is that Wallander is having the more likely the dominant condition. Second thing, whatever we are thinking about the Wallander, there will be extensor muscle involvement. As we can see here, the extensor muscle involvement is there. So there could be a possibility of Wallander also. The limb vacuole. The limb vacuole will be present in several conditions. Okay. The first of all, it could be present in the inclusion body myositis. They will be having the typical limb vacuole. Another important thing, they can have the limb vacuole as well. So that is the thing will, proves us towards the answer. So as the patient is having, there's foot drop, there's tibial weakness, the patient having limb vacuole, like tubular filament suggestive of inclusion body myositis, I think it's more in favor of Nonaka. So the patient having the Nonaka myopathy, whenever we think about the Nonaka myopathy, the patient having a distal variety, the patient having foot drop, weakness in the tibial muscle, eventually muscle of the upper limb affected, particularly extensor. If involvement of the proximal muscle, bulbar muscle involvement is quite rare. But the issue is that there is limb vacuole. Whenever we got a limb vacuole, there is a possibility of inclusion body myositis. There could be a possibility of Nonaka myositis. Okay. Wallander, on the other hand, it is a distal myopathy that is typically the autosomal dominant. It is begins the atrophy and weakness of the muscle of the hand and leg, particularly here also rim vacuole, but this is not compatible with the inclusion body myositis. The Marksberry gigs is autosomal dominant condition, distal myopathy. The issue is that there could be titin gene mutation in chromosome 2. There will be foot drop, there will be wrist drop, there will be extensor weakness. The biopsy can have this rim vacuole. But the rim vacuole typical of inclusion body myositis can have more common in Nonaka, right? So I without any doubt, this is a very painful question. The next question. A 46-year-old man present with diplopia occurring predominantly in the afternoon and prolonged reading or watching television. So it's more in favor of myasthenia gravis. Yes, she's diagnosis with myasthenia gravis on the basis of serological testing, prescribed pyridoxine 60 to be taken 3 times a day for diplopia. He presents to her physician 3 days later with diarrhea and crampy abdominal pain. Okay, after taking the dose of pyridostigmine. So what is correct regarding the pyridostigmine? It is choline esterase inhibitor, not acetylcholine agonist. So it is false. Second thing is that it leads to destruction of acetylcholine esterase. Okay. Commonest side effect is the crampy abdominal pain and diarrhea. It is actually called anticholinesterase. So it's inhibitor, not that much destruction, I guess. So it can increase the the abdominal cramping pain and diarrhea as the patient has some parasympathetic effect, and there is pyridostigmine CNS side effect. Okay, little risks of excessive dosing. I guess the C will be the most common answer. Acetylcholinesterase inhibitor, including pyridostigmine and neostigmine, they inhibit the acetylcholinesterase. So whenever they inhibit the acetylcholinesterase, the acetylcholine level in the neuromuscular junction will be increased. The most commonly used acetylcholinesterase inhibitor is pyridostigmine. It improves the symptom but does not alter the course of disease. So you should remember the fact. The side effect is due to activation of muscarinic receptor outside the neuromuscular junction. Sometimes there could be nausea, diarrhea, there could be increased bronchial secretion. If there is bad luck, there will be cholinergic crisis also. Okay, so excessive dosing, the cholinergic crisis can occur. The paradoxical weakness of the weakness, there could be respiratory failure. There could be the patient having myasthenia presenting with significant worsening of the symptom with respiratory involvement, should be assessed the possibility of cholinergic crisis. Okay, so the both condition can have the cholinergic respiratory involvement, like the cholinergic crisis or even myasthenic crisis. But the other condition of cholinergic features, that will differentiate. Okay. So cholinergic crisis result from overstimulation. So the symptoms will be nausea, vomiting, diaphoresis, sialorrhea, excessive secretion, meiosis, bradycardia, and diarrhea. Relate somewhere, it is typically just like a OPC poisoning. Okay, just a couple of minute break. So let's resume again. The recording is progress again. So the issue is that the 5-year-old boy for evaluation for a weakness and possible muscle problem. There is a muscle biopsy obtained. I guess what will be the correct regarding this condition? Okay. Okay. The issue is that correct information. Pathologically, there is a small course tracking mitochondria. Only a small segment of muscle fiber are a risk of the malignant hypothermia. Prominent distal muscle, intrinsic hand muscle. Okay. It could be some myopathy, particularly, the core myopathy is something called the multi-mini core, or I think there could be, central core myopathy. There could be deviant. The patient having central core myopathy more having the increased possibility of malignant hyperthermia as well. So yes, it is a central core myopathy. So let's check about the central core myopathy in the sorry, there's maps there, I guess. Okay. Okay. As you can clearly see, there is some, there is a lot of core devoid of any problem. Okay, these are the typical, the central core. Okay, so these are the typical central core, a lot of divoids. So issue is that in case of central core, it's an autosomal dominant condition having a mutation of ryanodine receptor 1 gene, or possibly chromosome 19. These patients having, increased risk of developing malignant hyperthermia. Okay, sometimes the patient having weakness, hypotonia after birth. There could be, weakness in the proximal muscle involving the pelvic muscle, having the shoulder girdle muscle, and particularly the pelvic weakness is more common, but the facial, bulbar, ocular muscle are typically spared. The CK is elevated. This is typically called the central core disease. Okay, so here we can clearly see there is some muscle biopsy. There's some, devoidance of chloride, as you can see. This is a devoidance, some dividers here. So the patient might be having a increased risk of malignant hyperthermia. So biopsies typically the typical features of central core myopathy. In this condition, there will be lesser activity of NADH, and so there will be less of oxidative activity in the central of muscle fiber. So the central will be a bit paler area in compared to because in the absence of the mitochondria. Okay, so there will be the pale area, that is very important. So issue is that the central course running along the length of muscle fiber in compared to mini-core or multi-core disease, where the core is small and extending through only the segment of the fiber length. Okay, central core myopathy is a autosomal dominant condition that is very high yield. So it is an autosomal dominant condition. Issue is there is RYR1 receptor mutation. There is increased risk of malignant hyperthermia. So whenever this should be considered whenever we're giving the patient a generalized anesthesia. Okay, the presentation can be there could be weakness, hypotonia after birth. There could be proximal muscle, pelvic or shoulder weakness that could be associated. Facial and bulbar weakness is typically spared. Okay, so facial bulbar weakness, we should always remember, typically more common in a patient of centronuclear or myotubular myopathy. Those patients having ptosis or extraocular muscle involvement as well. So let's take a differential between central core vs multi-core. Okay, there's a lot of core myopathies ongoing on. I guess all of these are central core disease. Okay. Okay. Now, as you can see, this is variation. Some variation is ongoing. It's not much central core. There's a multiple core, right? Multiple variable foci with decreased enzymatic activity in there. So there could be associated multi-core here, I guess. Okay. These are probably the multi-core, right? Okay. Okay, let's go to the next question. Some good question, I guess, not this types of pathetic question. So the issue is that a 52 years old, previously healthy woman noticed a significant lightheadedness on getting out of the bed in one morning. Okay, on the following next day, he's having such significant lightheadedness on getting out of the bed one morning. Over the past few days, his symptom progresses. 2 weeks after the symptom onset, he can barely sit or stand because of the severe lightheadedness. During this time period, she began to notice early satiety, constipation, and incomplete voiding after urination. Okay, denies any sensory or motor feature. The BP was supine, it's 160/90, heart rate of 75. On sitting position, it is becoming 120/75. So it's a significant postural hypotension. On standing position is another fall. So it is very important. So there will be significant postural hypotension without tachycardia. So the issue, what will be the possibilities here? Okay, as you can see, there is no tachycardia. So postural orthostatic tachycardia syndrome, the patient having significant tachycardia whenever he or she is having some postural component. So it is autoimmune or autonomic ganglionopathy. It could be a possibility. The autoamyloid, autonomic diabetic, autonomic or pure autonomic failure. Whenever you want to think about diagnosis of pure autonomic failure, we need to have a long history of time. Okay, the patient having history in particularly 1 to 2 weeks, so it's a short history. Whenever we think about short history, we should think about the autoimmune autonomic gangliopathy. It's over the weeks. Whenever we get a long history, particularly some over the time, so it's more in that case it will goes more in favor of pure autonomic failure, like the Bradbury-Eggleston syndrome, I guess the name of pure autonomic failure. So the patient having the history and diagnosis consistent with autonomic ganglionopathy or acute pan dysautonomia. Okay, acute pan dysautonomia. Sometimes there could be receptor that will be positive against ganglioside nicotinic acetylcholine receptor antibody. Okay, so they will involve over weeks in comparison to pure autonomic failure, which slowly develop over time. The symptom of autonomic ganglionopathy are due to dysfunction of the parasympathetic and sympathetic nervous system. That's why the patient having postural hypotension. There is some absent heart rate variability, also having hypohidrosis or anhidrosis, dry eyes, dry mouth, having pupillary abnormality, sexual dysfunction. There's some bowel troubles as well, like eyelid satiety, constipation, and diarrhea. Okay, the results is from the impairment of transmission of impulse from autonomic ganglia and affects both parasympathetic and sympathetic nervous system. Okay, so it can affect both parasympathetic nervous system, it can affect both sympathetic nervous system. In approximately half of the patient, an antibody against the ganglionic nicotinic antibody receptor. So we should remember the fact it's called ganglionic nicotinic acetylcholine receptor. In autonomic ganglionopathy, it can be either autoimmune or paraneoplastic. Okay, whether it could be autoimmune, it could be paraneoplastic. In paraneoplastic, we should think about the small cell lung carcinoma. It's a common condition that could be associated with malignancy. This cannot be definitively distinguished from clinically, as the antibody can be present in either form. Okay, so should remember the name ganglionic nicotinic receptor and acetylcholine receptor antibody. Okay. So in a patient having the autoimmune form, the other autoimmune disorder can be present. We should think about that as well. So whenever we want to treat a patient with autonomic gangliopathy, we should give the patient the plasma exchange. We should give the patient, apart from the plasma exchange, we should give the IV IgG. Okay, so plasma exchange and IV IgG, that could be an important treatment option. Okay, next issue is that the acetylcholine receptor antibody are typically seen in the autoimmune myasthenia gravis. Anti-striational muscle antibody can be seen in the myasthenia with thymoma. Sometimes they could be found in the autoimmune myasthenia. Sometimes they could be they can be also find. We can find it also in thymoma also. So antibody against the presynaptic PQ type of voltage-gated calcium channel, they could more common in Lambert-Eaton myasthenic syndrome. Anti-Jo1 polymyositis also can be seen in the dermatomyositis, particularly anti-synthetase in a case of ILD. Okay. Okay, in diabetes, without a known history of diabetes, autoimmune neuropathy will be unlikely to be a sole manifestation of nervous system involvement. The postural orthostatic tachycardia syndrome, and okay. Now, which one of the following antibody could be helpful in this condition? There could be helpful as it is autoimmune autonomic ganglionopathy. We should check about the ganglionic nicotinic acetylcholine receptor antibody. Okay, we should know the name as well. I told earlier about these facts as well. So we should remember the name of the antibody. It is where we get the information. Okay, let's mark this fact. It's a ganglionic nicotinic acetyl receptor antibody. Now, another painful question is ongoing. A 20-year-old man has bought for evaluation of weakness. The weakness predominantly involved the plantar flexion and atrophy of the posterior leg compartment. Genetic testing is obtained, confirming the mutation is dysferlin. Okay, the patient, his parents is not having any muscle disease. Which one of the following he is most likely to have? So we have already discussed a lot of myopathy already. So first of all, we discussed the myoshe. We have discussed the Wallander. Okay, Wallander is autosomal dominant, as I told earlier. So in that case, there will be predominantly apart from the proximal muscle, there could be some distal involvement predominant. Okay, so distal involvement is more common in Wallander, particularly it is autosomal. It is autosomal dominant condition. There could be associated, muscle atrophy. Okay, so the autosomal dominant involving the after 40 to 60 years, the distal muscle more common in Wallander, as I told earlier. Second thing is that there's the laying myopathy. It's a pathetic myopathy, I guess. There is also some distal involvement. This is the only thing I remember. Particularly here in case of laying, there is a particularly extensor involvement. It's more common, sparing the flexor one. Okay, so finger extensor will be involved in the laying myopathy. Okay, in Wallander, there could be also distal, but it's autosomal dominant. And there could be also extensor involvement, I guess, just like laying also. And the Marcus-Bury gigs, it's an autosomal dominant. There could be multiple foot drop, wrist drop. Also, in the extensor weakness could be there. So Wallander, Marcus-Bury gigs, and Lane, they all have the particularly the distal involvement. Also, they all having the extensor involvement in particularly. In Nonaka, I've told earlier, this is also distal, but the issue is that there will be some, whenever we do the biopsy will be rim vacuole. Rim vacuole will be present in the Wallander also, but the rim vacuole will be typical of inclusion body myositis. Okay. In case of Myoshi, we should remember there is posterior compartment atrophy. Whenever we get a posterior compartment atrophy associated having difficulty in walking the plantar flexion, okay, the posterior temporal wasting, having difficulty in walking in the using the sole, there's plantar flexion abnormality, tiptoe walking problem. So you should think about the dysphrenulopathy. So dysphrenulopathy typically associated with only one disorder, that is the Myoshi. Okay, so Myoshi, dysphrenul, okay, they are like, you know, the brother sister. So I guess this Myoshi could be the most important answer. The patient having Myoshi's, it's the autosomal condition, weakness, atrophy, the distal, just like the other condition, predominantly involving the posterior, predominantly involving the plantar flexion as well. Okay, the mutation of dysphallin also associated with limb girdle muscular dystrophy type 2B. Another mutation sometimes in the ANO5. I am not going to remember this thing. And the Nonaka, Marcus-Bury, and the Marcus-Bury and Wallander, they are discussed in the question 21. The laying also distal, it is, I guess, involving the tibial compartment, eventually extensor. That is only thing I remember. I'm not going to remember any further. So what the take-home message from this question? The Myoshi, dysferlin, typical involvement, okay? The Nonaka, typically inclusion body myositis-like feature. So Myoshi, dysferlin, Nonaka, inclusion body myositis. Okay. So I guess this question, a 22-year-old woman has presented to the emergency department having 2 weeks history of dyspnea and exertion. So there's having some problem whenever he or she is exerting. It is worsened for the last couple of days. On the past 2 months, he is having difficulty in swallowing. He noticed that holding her head up was effortful. On examination, she is deserting, using accessory muscle to breathe, holding her chin up. There is neck flexor and proximal arm strength as consulted to be 3 out of 5. The strength was not transiently improved with sustained contraction. She had no complaint of diplopia or any visual problem, not complaining any scapular muscle. Deep tendon reflex is normal. Admitted into ICU further evaluation. CK was normal. Acetylcholine was not detected, but EMG shows there's decremental response. So there could be acetylcholine negative myasthenia gravis. So other antibody, we should check about other antibody. The first antibody I should check, or we should check the muscle specific kinase. So history and examination typically like myasthenia gravis, and there will be anti-muscle specific tyrosine kinase antibody positivity. Sometimes a lot of people having seronegative for acetylcholine receptor, in that condition, the anti-mask antibody could be present. Okay, in patient with anti-mask antibody, the clinical feature results typical of the autoimmune myasthenia gravis. Okay. The weakness in case of anti-mask antibody, the clinical feature may resemble a typical autoimmune myasthenia gravis or ocular myasthenia, but more commonly weakness involving the proximal cranial and bulbar muscle with predominant dysphagia, neck flexor weakness with relative sparing of the ocular muscle. Okay, so issues that there is a lesser possibility of involving of ocular muscle whenever the acetylcholine receptor antibody is negative. This condition is typically common in young women. They typically does not respond to pyridostigmine. Okay, in that condition, whenever the patient is not having any acetylcholine receptor antibody positivity, we should give the patient particularly the immunoglobulins and plasmapheresis. That could be an important treatment. So anti-striational antibody is present, could be in myasthenia gravis, could be in thymoma. Okay, antibody, okay. So issue is that there is anti-Joe antibody in polymyositis, CK is elevated, the EMG shows myopathy. Okay, so let's have a break again. Thank you. And now the next question. A 29 years old man presents to the clinic for the evaluation of the weakness. He recalls that since he was a child, he was not able to keep up with his peers while running, biking, or recalls frequent falls when attributed to clumsiness. He has a proximal weakness, a difficulty in standing from sitting position, requiring the use of his arm to do so. Right. He faces difficulty to lift object. On examination, there's pseudo-hypertrophy of the cuffs. The CK is elevated. And the EMG shows fibrillation, positive wave. There is a myopathic motor potential as well. There is some problem of the fibers of variable size. There is segmental degeneration, regeneration, the area of fibrosis. Okay. The patient recalls that his maternal uncle has difficulty in walking, the wheelchair bound by 40s. So I guess it is a myopathy. The involvement is particularly in the later aspect. Okay, so it is not typical for Emery-Droux's, not typical for facioscapulohumeral, not certainly myotonic. I guess it's the Baker's. Okay, so the Baker's muscular dystrophy, a milder dystrophinopathy, similar to Duchenne muscular dystrophy, but in which the Duchenne protein is not completely absent, but it is present in a smaller manner or structurally abnormal. That goes more in favor of Baker's muscular dystrophy. It's the X-linked recessive disorder. The weakness and involvement of the same muscle group like the Duchenne muscular dystrophy, but later presentation with less severity. Okay, so there could be pseudo hypertrophy of the calf. However, the patient of the Baker's presents later in the life, sometimes in the childhood, more frequently in the adolescence and adulthood as well. Okay, the patient might be having some cardiac involvement, some having some, the IQ is usually normal. So the cardiac issues is there, the cardiac involvement is less frequent, but the IQ is usually normal. Okay, whenever you want to do a EMG, we can find that the IQ is diminished in Duchenne muscular dystrophy. The EMG shows the fibrillation, positive wave. Okay, the polyphagic short motor unit potential as well. The biopsy shows similar to Duchenne muscular dystrophy, but dystrophin is not absent in Becker's muscular dystrophy. It's structurally abnormal or present in a smaller than normal amount. So dystrophin is a cytoplasmic protein that attack with the other protein like the F-actin. They can link to a transsarcolemmal dystrophin protein glycans, which provide a structural link between the sarcolemmal cytoskeleton or extracellular matrix. So that is very high. If dystrophin is lost or are altered, the sarcolemmal structure is affected, making it susceptible for rupture. Okay, it can having susceptibility to rupture as well. Which one of the following condition? The cardiac involvement occur early. It's not true. The IQ is normal in this condition. It's X recessive without any doubt. And dystrophin is not completely absent. Alteration of dystrophin makes the muscle or sarcolemma more susceptible to rupture. So X recessive could be the answer. The next possibility is that a 40 years old woman presents with weakness. She has difficulty in standing from sitting position, walking up the stairs. She also complains difficulty in lifting her arms above the head whenever she washes her hair. Okay, so there is some problem in lifting her arms above the head when she washes her hair. On examination, there is a purplish discoloration of the eyes. His face look edematous. There's purple scaly rash on the extensor surface of the hand. The palmar region is thickened. CK is elevated. Okay, so I guess the diagnosis is already achieved. As the patient is having difficulty in standing from sitting position, also having some skin involvement as well, dermatomyositis could be the most possible answer. So the patient might be having dermatomyositis. The use of methotrexate should be avoided if the patient having ILD, because this medication could be toxic to lungs. The dermatomyositis is the inflammatory condition having skin problem. Sometimes the patient might not be having any skin problem. This is called sign dermatitis. So the dermatomyositis is an inflammatory condition of the muscle that is associated with skin findings. The muscle weakness having typical myopathic weakness. The weakness is more likely to be proximal weakness. The patient will complain being able to stand up, unable to stand up from a sitting position, unable to walk. Typical skin findings will be a heliotrope rash. There could be erythema of the face, neck, and antrochest. Okay, so there could be heliotrope rash, there could be Sol sign, there could be Gordon's papule, there could be these findings are pretty much common. The patient might be having the thickening of the dorsal and ventral surface of the skin. So this is called the mechanic hand. Okay, so CK is elevated. The muscle biopsy is typical. They shows the atrophic fiber, particularly the perifascicular atrophy. This is typical for dermatomyositis. They can be associated with malignancy, particularly whenever the dermatomyositis can have ILD, there could be JO1 positivity. This is very high yield. Okay, whenever we're thinking about any particular malignancy associated with dermatomyositis, the commonest malignancy will be ovarian malignancy. Okay. So regarding the condition, what is the most possibility? Steroid could be a treatment, could be ILD, could be perifascicular atrophy. If the age is susceptible, we should do a malignancy working because some young onset dermatomyositis could be less than 18 years presentation. So it is unwise to choose malignancy in a wholehearted manner in that case. So in that case, methotrexate should not be used. If there is ILD, and ILD will be exacerbated. Now the next question, the patient complaining a woozy dizziness over the prior year. Whenever he would wake up in the morning, still lying in the bed, he would feel fine. Okay, his wife checked his blood pressure once early in the morning, is found to be 180/90. As soon as he would get out of the bed, the woozy feeling would occur and typically last throughout the day. His blood pressure is low in 80/60 when standing. He is particularly symptomatic after eating, and whenever the weather is warm, whenever the weather is warm, and he also lost consciousness twice prior months. All episodes triggered by changes in posture. So there's a postural hypertension ongoing, but what will be the etiology? I should check. Okay, there's a year history of importance. So there is some, the autonomic nervous system involvement, also complaining the nocturia, urinary incontinence, hesitancy. Okay, there apart from besides the demonstration of orthostasis on vital signs testing, his examination is entirely normal. No evidence of ataxia, rigidity. So what will be the most possible answer in this scenario? Okay, let's take the scenario. It is difficult to appreciate autoimmune autonomic ganglionopathy within the period of only it's a long period of time. It's a short period of time. There is no familial history so far I recall. So familial amyloid angiopathy or neuropathy. Sorry, familial amyloid neuropathy could be less possibility. Diabetic autonomic neuropathy, there is no history compatible with diabetes, no history of the multiple system atrophy. I guess it's pure autonomic failure, or it could be, as I told earlier, in this condition, the pure autonomic failure should come first. That could be a Bradbury-Eggleston's disease. Okay. The patient history is compatible with the pure autonomic failure, which is also known as the Bradbury-Eggleston syndrome. The patient, why this problem? The patient may be having the interomediolateral cell column damage. Okay, sometimes there could be some associated Leo body. Okay, can be seen. So the issue is that the most commonly in case of male, the earliest possible symptoms is importance. Okay, then it could be associated with significant postural drop, that is more than 20 in systolic BP or more than 10 in diastolic BP, or eventually both. Okay, the pulse rate will be increased or approximately 20. It's more common in the morning, after meal, after exertion, when we need this. Okay, supine hypertension can occur. This is very likely. So supine hypertension, we should remember the fact, because in the lying position, the nerves will be acting, but in the standing position, nerve will not be making the compensatory effect. Okay, so there could be nocturia, hypohidrosis, early satiety, nausea due to GI mobility changes. There could be, coat hanger distribution. The patient might be having the neck or shoulder aching. Okay. In case of multiple system atrophy, this heteronemia is typically more severe and disabling. Okay. The patient might be having the extrapyramidal feature, might be having a cerebellar feature as well. Okay. Familial amyloid neuropathy type 1 can lead to autonomic neuropathy, but other features is not that much compatible here. Now, the next question, there's a muscle biopsy ongoing. The patient having proximal weakness, there could be some progressive weakness of the proximal muscle of the upper lower extremity, no skin rash, CK elevated, muscle biopsy, 35 years old. Which one of the following is correct? Okay. Okay. Now, whenever we think of this, we should think about some particular issue. Whenever you get a perifascicular atrophy that goes more in favor of dermatomyositis, the rimmed vacuole that goes more in favor of inclusion body myositis. In that case, the wrist and finger flexor and quadriceps will be typically involved. Patient might be having any dysphagia with elevation of the CK level. Okay. So in this condition, it is more in favor of inclusion. Sorry, it goes more in favor of polymyositis. Okay. So in case of polymyositis, as you can clearly see, there will be inflammatory infiltrate of the lymphocyte and macrophage that will be surrounding the muscle fiber. There will be necrotic fiber. So inflammatory infiltrate with necrotic fiber alongside of the muscle fiber that goes more in favor of polymyositis. Okay. So sometimes the rimmed vacuoles more in favor of inclusion body, or perifascicular atrophy more in favor of dermatomyositis. Rim vacuoles can be seen in the inclusion body myositis, perifascicular atrophy more in the dermatomyositis. Okay, the polymyositis, the inflammatory condition of the muscle, there will be no skin changes. The weakness is proximal, particularly more in favor in the fourth decade, fifth decade, eventually in sometimes third decade also. The weakness may be proximal. The weakness in this condition could be similar to dermatomyositis. The patient might be having ILD. Whenever we think of ILD, we should check about anti-synthetase or anti-Jo antibody. Okay. So on the hand, polymyositis is opposed to dermatomyositis. Like that, there is no history of malignancy. Malignancy goes more in favor of, strongly suggests the dermatomyositis in susceptible age. The particular treatment is steroid. We should remember sometimes whenever we're giving the steroid long term, then we should give the patient methotrexate or azathioprine as well. So a subset of the polymyositis, the patient having anti-Jo or even the tRNA itself. Now the next question, a 61 years old diabetic hypertensive hyperlipidemia suffered a stroke about 1 month ago. At the time, he was started aspirin, clopidogrel and statin. Now he's complaining weakness, myalgia, oliguria. He seems to be fluid overloaded, so there could be acute renal failure as well. The blood urea nitrogen and creatinine is very elevated, so I guess there is renal failure. Possibly due to the myalgia there with renal failure. The myoglobinuria can cause renal failure. As further evidence by CK is further most elevated, so I guess it's most likely myoglobinuria. What will be the cause of it? Okay, so corresponding with the scenario, there's no history of fall, there's no history of any drug. Okay, sorry, drug, that means I'm asking about the alcohol and other the substance abuse. So there could be a drug in this scenario, the statin. So issue is that statin could be an important issue here, because rhabdomyolysis is not that much common in low dose statin, but it can causes the immunomediated the necrotizing autoimmunomyopathy can be caused by statin in some aspect, but it's not a common condition, right? The LDL mutation, I don't know. The statin-induced myalgia cannot be associated with CK in the all time. Okay, the elevation of CK resulting from statin exposure always have clinical manifestation, not likely. The concomitant statin or fibrate. Whenever two drugs having myopathy, like statin alongside fibrate, statin alongside with the azoles, statin alongside the macrolides, which is also enzyme related activity. So statin fibrate, statin azoles, statin macrolide, statin zidovudine, statin amiodarone. They can cause significant muscle toxicity in some cases. So I think here will be best possible answer is statin and fibrate, I guess. So concomitant use of statin and fibrate can increase the muscle toxicity. Statin that helps in 3-hydroxy, 3-methyl glutyl coenzyme A reductase, HMG-CR. So HMG coenzyme A reductase inhibitor is particularly statin. So statin can have a toxic effect to the muscle itself. Sometimes it has some action on the mitochondria and sarcoplasmic reticulum, typically involving the type 2 muscle fiber. Okay, so it will typically involve the type 2 muscle fiber. Particularly, there are certain causes of type 2 muscle fiber involvement, particularly steroid, particularly statin. Okay, sometimes there could be some mutated genes there involving, the SLCO1B. This gene mutation can have, predilection as a propensity to develop statin-induced myopathy. So you should remember the gene. So SLCO1B having a increased predilection of having LDL mutation. In that condition, there could be a statin-induced myopathy. Okay, so that could be a possibility there. So in a nutshell, whenever the muscle toxicity, statin, it will cause type 2 muscle fiber damage. If there is any mutation to SLCO1B, there will be increased predilection of statin myopathy. Usually, a statin causes sometimes asymptomatic elevation of the CK. The mild elevation could be there. Sometimes the myalgia can have a association with increased CK or not. Okay, but rhabdomyolysis is a certain issue. With renal failure, it's very important. Okay, sometimes statin can cause necrotizing autoimmunomyopathy. This is the severe muscle weakness. CK is very much elevated, particularly more than 6 to 7,000. They having the weakness, dysphagia. Okay, and progress after discontinuing statin. That is very important. In this condition, there is predisposing antibody to anti-HMG CoA reductase antibody, also associated with signal recognition peptide, SRP antibody could be there. So in that condition, there could be more propensity to develop autoimmune antibody-induced muscle damage. So this is very important here. There could be issue. And necrotizing autoimmunomyopathy, the level will be more. There will be distal weakness and dysphagia. There will be antibody to HMG CoA reductase inhibitor. Also, there could be antibody positive to signal recognition peptide also. So biotoxicity of the statin is enlarged more whenever we give the patient statin with other drug like the fibrate, or having azoles, or having any macrolides, antiretroviral or amiodarone. So we should treat the patient with cautiously in this scenario. Okay, some statin having a increased propensity or high lipid lowering potency. So particularly whenever we give the statin with a particularly high cholesterol lowering potency, they having with higher statin dose, the higher statin, higher lipocity can have a role here. Okay, so the lipophilic statin, including the atorvastatin or simvastatin, so these are more lipophilic. They have more myotoxicity, and on the contrary, the rosuvastatin or fluvastatin or pravastatin. So prarosu and fluvastatin, they have a lesser propensity to developing the myotoxicity. Okay, so you should remember this fact as well. Now, next question. A patient with depression, migraine, chronic fatigue syndrome, having palpitation and lightheadedness over every time he stands up from sitting position. This symptom never occur whenever he's seated or supine. On vital testing, the pulse rises from 30 to 130 whenever she is standing. Her examination, otherwise normal. tiltable test confirming the increase of pulse from 80 to 150, okay, particularly in the head tilt above 70 degree. The blood pressure remains stable. So the issue is not due to only the postural hypotension. So I guess the patient having, whenever the pulse rate is increases, if she feels palpitation, lightheadedness, and weakness, so the all other tests is absolutely normal. So I guess it's more in favor of postural orthostatic tachycardia syndrome, the spots. We should remember this fact as well. So patient history and tiltable tests are compatible with POTS. It's one of the commonest form of dysautonomia. So in this condition, the tiltable test, particularly we arises the changes with posture, particularly the particularly that will more involve the pulse and blood pressure. Okay, so pulse and blood pressure at the time of the posture. Okay, so sometimes in response to admission of the pharmacological therapy such as the isoproterenol, in case of postural orthostatic tachycardia syndrome, the POTS, the tiltable test shows the increased heart rate at least 30 from the baseline. We should remember. So there could be increased heart rate of 30 from the baseline. Whenever we got a heart rate increase more than 30 from the baseline, we should think about postural orthostatic tachycardia syndrome. The etiology is quite unclear. Okay, more common in female, particularly worsen at the time of menses. Thus that there could be association, some role of the estrogen. So some recommended, estrogen therapy in these patients as well. So the POTS could be a manifestations of the mutation of the norepinephrine transporter gene, which might be lead to increased level of norepinephrine, which may lead to increased level of the sympathetic overactivity. Sometimes it could be comorbid condition of chronic fatigue syndrome as well. Okay, so in this condition, sometimes the role of beta blocker could be explained. Okay, so we should remember about the estrogen association. We should remember about the chronic fatigue syndrome. Okay, these things can be associated. So in this condition, there is not a reduction of blood pressure in POTS. Distinguish it from other causes of postural hypertension. There is no blood pressure abnormality. With vasovagal syndrome, there will be, no tachycardia because there's some bradycardia due to parasympathetic overactivation. Systemic mastocytosis is a muscle tumor. There could be increased, association of wheeze, having some skin lesion, having increased amount of, the histamine, or having muscle tryptase activity. They can also having this sort of extensive tachycardia, but the patient might be having flushing, having some, skin changes. They are quite common in this scenario. Another important thing that is clearly a different thing, subclavian steal syndrome. So a 45 years old man, originally from the China with a history of palpitation and anxiety, presents with recent onset of weakness involving the arms and legs. Okay, so there is a palpitation, anxiety, now having some weakness involving the arms and legs. Is not actually unilateral. He feels paralyzed, sparing the recipient bulbar muscle. So I guess you should take a thyroid level. It is most likely thyrotoxic periodic paralysis. As the patient is having thyrotoxic periodic paralysis, adult onset periodic paralysis, should you think about the thyrotoxic cause. Okay, it's a condition that may lead to hyperthyroidism. Okay, sometimes there could be genetic susceptibility, but without a known mutation, is still not detected, I guess. More common in Asian with male predominance, patient having some history and features of thyrotoxicosis, then have typically these sorts of symptoms. Okay, so the issue is that whenever we're dealing with the case of thyrotoxic periodic paralysis, we beta blocker may be of benefit, but during the attack you should give the patient potassium also. Okay, but it is not known whether this thing is happening. So thyrotoxic periodic paralysis, we should remember the fact. Okay, so in this case, the next step to check a thyroid stimulating hormone level, the needle UG is not actually typically a myopathy. We should not take it first. First, we should check the thyroid level. Okay. Now the next question: patient having asymmetrical atrophy and weakness of the wrist and finger flexor, also quadriceps involvement. Diagnosis is also there. Okay, there is deltoid spared, similarity to facioscapulohumeral dystrophy. CK is elevated. Age is more than 50. It is inclusion body myositis. Okay, the patient typically having inclusion body myositis is a myopathy involving adults older than 50. There is asymmetrical weakness involving the wrist and finger flexor. Also, there could be quadriceps. Sometimes there could be anteriotibial involvement. So anteriotibial muscle involvement could be there. The dysphagia can present. There is no skin manifestation. There is no skin manifestation. CK sometimes could be elevated. We should remember this fact as well. The biopsy specimen shows endomysial inflammation. Okay, there could be most important fact is that apart from the endomysial inflammation and atrophic fiber, there is rim vacuole. So rim vacuole is typically characteristics of the inclusion body myositis. There is another condition having a typical rim vacuole, as I mentioned earlier in the Nonaka. Nonaka has this typical rimmed vacuole of inclusion body myositis, right? Okay, so this is perivascular atrophy. Perivascular atrophy is more common in I guess dermatomyositis, rim vacuole inclusion body, Gotter papule dermatomyositis, mechanic hands dermatomyositis. Response well to prednisolone, it is more in favor of polymyositis or dermatomyositis as well. So the patient having inclusion body myositis, CK can be mildly elevated. The issue is that there is intracytoplasmic vacuoles on a granular material known as the rim vacuole, which is characteristics of inclusion body myositis. Okay. Now, next question. What will be the incorrect whenever we try to manage a case of limb-girdle muscular dystrophy? Screening for cardiac involvement. Of course, we need to check a lot of condition with limb-girdle muscular dystrophy. We need to check the cardiac involvement. The gene therapy and myoblast transplantation should be offered. Okay. The physical and occupational therapy should be used to prevent the contracture. Okay. And the pulmonary function test should be performed at the time of diagnosis. Sometimes, okay, there could be maintenance of nutrition via oral route not possible. Okay. So the first important thing is that the best answer is we should not, goes in more favor of gene therapy and myoblast transplantation. That should be the best answer. Otherwise, we should check for cardiac involvement in some cases. Physical therapy should be started. Pulmonary function should be ensured. Sometimes the all other option makes sense. Okay, do make sense. So sometimes, according to American College of Neurology, they have a lot of variety of limb-girdle muscular dystrophy. So should not offer the gene therapy or myoblast transplantation or neutralizing antibody or growth hormone. These are not that much indicated, is still recommended. Okay, they are not recommended correctly. So the cardiac involvement, including cardiomyopathy, including the conduction defect, is evident in various types of limb-girdle muscular dystrophy. Screening of them are recommended even in the asymptomatic patient. So it is a typical group of disorder having a lot of variety. Okay, it can present in both sex. It can having a involvement of the autosomal dominant, particularly the type 1 variety, type 2 having the autosomal recessive variety. Okay, considering the limb-girdle muscular dystrophy type 1, it's autosomal dominant, and type 2 is recessive. In this condition, there will be dystrophic change, also necrosis, degeneration, regeneration, muscle fiber variation. They're typical of myopathic changes. Okay, endomysial inflammation and fibrosis. Some limb-girdle myopathy associated with joint contracture. Some, in that case, you need to give the physiotherapy. Some patient having swallowing difficulty, orophageal dysphagia. In this condition, we should give the patient the feeding tube. Okay, so the next question. A 10-year-old boy brought for evaluation of proximal weakness, and that involved the predominantly pelvic girdle. Okay, so very vague question. A limb-girdle muscular dystrophy is suspected. Which one of the following proteins is associated with respective type of limb-girdle muscular dystrophy? So there's a protein-related issue, right? So there's a lot of protein-related information regarding limb-girdle muscular dystrophy. I need to check the correct one. Okay. So whenever we're thinking about the cavalier, it's a rippling muscle disease. Whenever we think of rippling muscle disease, we need to think correctly about the. Okay, when I think about 2A, The 2 is typical calpainopathy. It's an autosomal recessive. The 2B is typical dysphenolenopathy. It is a 2B. Okay. The 1 is certainly not dysphenolenopathy. Dysphenolenopathy is a limb girdle muscular dystrophy 2B. Fukutin, I guess this is the answer. This is the best answer. Fukutin related, I guess it's 2I. Yes. Yes. So, as mentioned in the question 41, the limb girdle having a very large amount of cases, a lot of cases is there. So, there is some autosomal dominant one, there's some autosomal recessive one. Okay, we should not, go much more details into that, but have some glimpse about that. Because, sometimes there could be a limb girdle muscular dystrophy. If that is autosomal dominant variety, so that could be 1A, that could be 1B, C, D, and E. Okay. What I need to remember, the important cause is limb girdle myopathy 1A. They will tend to involve morely motility. Okay. 1B, morely involved in lamine. Okay. So when we are thinking about the lamine, so there could be an association of, laminin. So it could be, I guess, Emily-Dreyfus. A lot of cases of Emily-Dreyfus muscular dystrophy can have this association of lamine. Okay. Okay, so there is another important thing. 1C, I should remember. C for cavalry. C for cavalry. Cavalry 3 is a rippling muscle disease. We should remember this fact as well. And now the big list, the big thing, the autosomal recessive form. There's a lot of variety there. But what we need to remember, the importance one. The 2A is calpainopathy. It's a calpainopathy. Okay. 2B, typical dysphenolenopathy. That is very important. And 2C to 2F, that will involve the sarcoglycanopathy. In case of sarcoglycanopathy, they can involve firstly gamma, then alpha, then beta, then delta, I guess. So 2C-D-E-F, that is important. Telethonin, that could be 2G, and ubiquitin ligase 2H, but important thing is that 2I, that is fukutin. Okay, fukutin is very important. Is 2I is fukutin, 2J is titin. Okay, important. 2K is also important, POMT1. 2L is as we learned earlier, ANO5. Okay, and not the least, 2M associated with fukutin also. Okay, so 2I is fukutin related protein and 2M is only fukutin. Okay, so in that condition, the fukutin is due to Fukuyama. The Fukuyama muscular dystrophy. Okay, making the things harder, I guess. Okay, the next question. A 52 years old woman who smoked since adolescence present to the clinic complaining weakness in the arms, that she has noticed that while blow drying her hair and weakness her limb, blow drying her ears, because sometimes using of the arms, and weakness in the leg, particularly climbing stair. So there's a myopathy. Associated symptom including constipation and sensing of incomplete evacuation of bladder. On examination, there is some proximal muscle involvement, there is some hip flexor involvement, deep tendon reflex present. After brief sustained contraction of the biceps muscle, the tendon reflexes increases. Okay, so as you can clearly see, there's some median compound median action potential. We'll talk about this later in the subsequent classes, I guess. So as there is stimulation of the wrist, elbow, a lot of thing is ongoing. Okay, the issue, it's more in common after post exercise. So initially, as you can see, initially the what clearly we can clearly see the initial level at the stimulation, the compound muscle action potential, that is the muscle activity, the initial level that is a bit low, but whenever you know the post exercise, the level is increases. So it is post exercise, stimulation or post exercise increment that goes more in favor, for lumbar eaton myasthenic syndrome. So I guess it's lumbar eaton myasthenic syndrome, the consistent, it's a form of myasthenia. It is the problem of the neuromuscular junction affecting the voltage gated PQ channel. So initial spec, it is more commonly associated in male, particularly in the malignancy. You should need to exclude the proximal leg weakness. You should remember the proximal leg weakness, the common manifestation of lumbar eaton. The weakness may be out of proportion to the examination. While in lumbar eaton myasthenic syndrome, the worsening of the muscle weakness with repetitive muscle exercise, they tends to get improvement. Okay. While in comparison to myasthenia gravis, the deep tendon reflex initially present, but whenever we try to exercise, do the activity, they tends to become diminished. Okay, so autonomic features are particularly common in lumbar myasthenic syndrome because there could be constipation, there could be retention and importance as well. Lumbar myasthenic syndrome can have a autoimmune or paraneoplastic one. They can be autoimmune, they can be paraneoplastic. Paraneoplastic lumbar eaton myasthenic should be associated with lung cancer. Okay, so we should remember this fact as well. Paraneoplastic might be associated with lung cancer. A diagnosis of autoimmune lumbar myasthenic syndrome can be made after excluding the occult malignancy. So first, whenever we want to think a paraneoplastic lumbar eaton myasthenic syndrome, we need to exclude malignancy first. After exclusion of malignancy, we should think about that. There is an antibody we should remember, the SOX antibody, anti-SOX. They could be positive in some cases. In particularly, is an important marker to distinguish the squamous cell carcinoma associated lumbar eaton and autoimmune lumbar eaton myasthenic syndrome. Okay, so anti-SOX antibody can have a good differentiation regarding the lumbar eaton myasthenic syndrome. Unlike, sorry. So what we should remember, the SOX antibody, SOX antibody particularly present whenever a patient having the paraneoplastic lumbar eaton myasthenic syndrome. Unlike the myasthenia gravis, the patient with lumbar eaton myasthenic syndrome will be having less responsibility to acetylcholinesterase inhibitor. We should give the patient a 3,4 diaminopyridine. Okay, that will inhibit the presynaptic potassium channel. So the depolarization will be there. The thing that was maintaining by calcium channel is now maintaining by depolarization through potassium channel. So there will be the there will be fusion of the vesicle. There will be exocytosis of the neurotransmitter. So that might help in this scenario. Autoimmune lumbar eaton could be treated with immunosuppressive therapy, with steroid, with steroid sparing agent, particularly also involve the lumbar, the IV IgG or plasmapheresis. Okay. And whenever we're thinking about the paraneoplastic, only one thing is important. It is the treatment of the malignancy. They may help. Here the EMG, they shows the initial level, there is low amplitude, the compound motor action potential. But whenever there is some brief exercise, there is increment of the compound motor action potential from the baseline. So this is called as facilitation. So this, the typical facilitation typically seen in the patient of lumbar eaton myasthenic syndrome. Now, the next question about the correct information. The symptoms not responding to acetylcholine, it's not true. Not in female, I guess. The autonomic involvement is pretty much, usual. So malignancy could not be, could not be present. It is due to antibody against the presynaptic voltage gated PQ channel. So E will be the best possible answer in this scenario. Now, a previous healthy 42 years old man having a puffy eyelid, diplopia, dysphagia, myalgia, having proximal weakness greater than the distal muscle weakness. CK is mildly elevated, eosinophils elevated. Whatever thinking of CK elevated with eosinophilia, we might need to exclude the parasitic cause as well. So considering the parasitic cause, one of the most commonest cause is trichinosis spiralis. So I guess trichinosis could be the best answer. As you can clearly see, the trichinosis, the patient might be having trichinosis. Patient was previously healthy, now having some muscle disease, having increased CK. Typically, as you can see, there is some parasite in the biopsy. Okay, so it could be trichinosis spiralis. So it is caused by a nematode called trichinosis spiralis, which is transmitted particularly whenever one person take undercooked pork. The pork containing must be encysted larva. Once ingestion, their cyst could be liberated in the GI tract. They can from the adult form, they can have a lot of issues there. Patient might be having a mild gastroenteritis after having the infected meat. 1 weeks later, that he's having some myalgia, fatigue, also having some edema, diplopia could also there. So there could be involvement in the the pharyngeal muscle also. So there could be masticative muscle involvement also occur in pretty common in this scenario. So limb muscle weakness occur. There could be some proximal weakness. The diaphragm and cardiac muscle involvement can also be occurring in this scenario. Okay, so myopathic syndrome eventually subside. Patient will gradually improve, I guess. So how about the massive infection? Sometimes reported, they can have headache, neck stiffness, and confusion as well. So whenever we do the lab test particularly demonstrate the eosinophilia in this scenario. Also, and there could be elevation of the creatinine kinase. The enzyme leak in the ELISA, whenever you do, that is typically positive after 1 to 2 weeks. The muscle biopsy will demonstrate the changes as well. Whenever we try to treat, we can give the patient with albendazole with steroid. Albendazole that prevent the reproduction. Okay, thibendazole can be used. Albendazole can also be used in this scenario. Okay, Lyme disease, HIV and Lyme disease. HIV can cause myopathy also. Lyme disease typically cause neuropathy, not myopathy. Okay, and okay, this is the best answer is trichinosis spiralis. Now, an infant has been brought with the evaluation of hypotonia. On the muscle biopsy, there is sarcoplasmic rod consistent with nemaline myopathy. So diagnosis there. So what will be the foreign is correct regarding the condition? So whenever you think about the sarcoplasmic rod in the muscle biopsy, always think of some condition like congenital nemaline myopathy, sometimes some late onset nemaline myopathy in the adult. In some other aspect, the HIV can also causes sarcoplasmic rod consistent with a nemaline variety of myopathy. Okay, so the correct answer is not actually invariably the neonatal period because adult onset could be manifested. Okay, respiratory muscle is spared in HIV cases. Okay, sometimes the respiratory muscle could be involved, but it could be spared also. The mutation is due to fukutin gene. There could be dysmorphic features as well. So there is a lot of information. So you need to check about the correct information as well. So the issue is that respiratory muscle is commonly involved apart from the HIV-related cases. Only the HIV-related cases, there will be some sparing of respiratory muscle involvement. Just a minute. Okay. So if we are dealing with a nemaline myopathy, they have a lot of phenotypic variability. Sometimes it can present in the young age. Sometimes in the some patient having some adult onset. Okay, so there is a lot of variant of symptoms. Okay, sometimes the patient may having the proximal weakness, also having some cardiomyopathy, also having the respiratory problem. These are the common feature. Okay, so there could be cardiomyopathy and respiratory problem. Only the respiratory problem is spared in the HIV-related cases. Otherwise, there could be respiratory muscle involvement in typically. In the young, the neonatal onset can have the dysmorphic feature, also having the contracture, having hypotonia, feeding difficulty. Okay, so that is phenotypically heterogeneous. They can be autosomal dominant, they could be autosomal recessive. Some patient might be having the issues of there could be a mutation in the NEB gene or ACTA1 gene that could be associated. There will be a lot of protein could be affected. Okay, whenever you do a histopathology, you can check a rod-like structure that will be beneath the sarcolemma. This is typical of nemaline lot or the nemaline bodies. Okay, so here there will be the type 1 fiber will be smaller. Okay, so that is very important. So let's take the next question. Okay, so regarding the testing of autonomic nervous system, which one of the following information is correct? Is incorrect. Okay. Okay, which of the following information is incorrect? Tiltable testing is a measurement of autonomic function and assess the changes of the blood pressure of the heart that changes. Okay, whenever we want to check tiltable is a typical onset, we can easily check that. It's true. Second thing is that normally with assumption of upright posture, there's transient bradycardia and hypotension. Okay, so there will not be any transient bradycardia with hypotension, followed by normalization of blood pressure and heart rate. Okay, whenever upright posture, there is transient bradycardia. I guess B will be the incorrect option. Okay, I'll come to other option as well. In the evaluation of syncope with upright tiltable testing, there is reduction of blood pressure with bradycardia, signifies a neurocardiogenic mechanism. Thermolaboratory sweat test is a quantitative test of the pseudomotor function. Of course, it identifies the pattern of sweating abnormality with the different form of dysautonomia. It's absolutely correct. The patient having the qualitative pseudomotor axon reflex is a measure of pseudomotor function that is specifically assesses the sympathetic postganglionic axon. Okay, so pseudomotor axon reflex test is an important function of the pseudomotor action, right? Pseudomotor action. I guess the B will be the best answer. So let's talk about this further. Normally, with an assumption upright posture, there is transient reduction of blood pressure, counteracted by there will be increased heart rate, not bradycardia, right? It's mediated by the inhibition of the parasympathetic nervous system and activation of the sympathetic nervous system. The splenic, renal, and skeletal blood vessel constrict because the blood is not necessary during a time of standing. We need to give the blood to the brain and heart. So it should not, it's not like that we are, standing and doing defecating, standing and doing urinating. So the blood should be lesser in the GIT, skeletal and renal circulation. The increased heart rate is maximum at 15, but at 15 beat, and there is mild reflex bradycardia in the 13 beat. Okay, in moderate to severe autonomic neuropathy, the compensatory increase in the heart rate will not occur. So that is the issue that when we think about the autonomic neuropathy. So upright tiltable test is important to objective measurement of the blood pressure and heart rate in the various posture. In normal individuals, the 60 to 80 degree of tilting for 10 minutes, or there could be some brief reduction of blood pressure. Okay. Okay. If there is gradual and sustained hypotension following the 20 systolic blood pressure reduction without any compensatory tachycardia, that is very important. Okay, hypotension with compensatory bradycardia suggests hypotension with compensatory tachycardia suggests hypovolemia. If the hypotension is delayed for several minutes, then occur abruptly with bradycardia, more suggestive of neurocardiogenic mechanism. So issue is that whenever a patient came to us with having low BP, having tachycardia, so you think about the less fluid. When you think about that, yes, there is a hypotension, okay, and that hypotension occurred abruptly with bradycardia. There's an issue is that the problem in the bradycardia. So they're having some neurocardiogenic mechanism because there should be tachycardia. There should be tachycardia if there is the neurocardiogenic system is all right. Okay. When there will be hypotension, there must be tachycardia. If there is normal neurocardiogenic response, when there be hypertension, there is bradycardia. You're thinking that the problem is in the heart contraction, or there's a problem in the particularly neurocardiogenic mechanism. Thermoregulatory sweat test is a test of the pseudomotor function. It is the sweat test, particularly checking the sweat. Okay, the issues of sweating, different type of anhydrosis or hypohidrosis can have a lot of disorder. We should think about that. Particularly sometimes the diabetic neuropathy can have the distal anhydrosis. The multi-system atrophy can have anhydrosis. A lot of condition that is typically associated. The quantitative pseudomotor axon reflex test, it's another test of pseudomotor function. So sweat test and quantitative pseudomotor axon reflex test, these are the tests of pseudomotor function. In that case, a sweat test, a sweat cell has been identified and electrical current has been applied. Okay, the acetylcholine is iontophorized into the cell stimulating a sweat gland. So at that moment, we are checking the sweat production that will be measured via the axon reflex. The low or absent response following this application that indicated the problem in the postganglionic sympathetic action. Because the preganglionic, we are giving the impulse, the postganglionic fiber is not working. So that's why the sweat is not forming there. Now, the next question. A 1-year-old child having evaluating for feeding and cyanosis. He is hypotonic, weak, noticed to have macroglossia, cardiomegaly, and hepatomegaly. So what will be the most possible? Oh, a diagnosis of Pompe's is already made. Okay. So whenever we think of the Pompe's, it's actually the second disease. So what is the incorrect? Issue is that the problem here, there will be less glucose, first of all. Okay. There will be less glucose. So there should be, the issue is that there could be glycogen accumulation, a lot of tissues there. So there could be due to acid maltase deficiency. Number 2, it could be autosomal recessive. The issue is that there could be Pompe's disease is type 2, right? So in case of whenever talking about type 2 but Pompe's disease, there is a problem including the 1,4-glucosidase enzyme. That is the issues there. The problem in the 1,4-glucosidase level. So 1,4-glucosidase is not, the level of the 1,4-glucosidase will be decreased. The patient is having some problem. Okay. So there could be glycogen accumulation causing a lot of, vacuolated cytoplasm. The organ will be enlarged. Okay. Patient might be having macroglossia, hepatomegaly, cardiomegaly. These are the common issues there. So I guess it's the issue is that it is type 4 glycogenosis. The type 4 glycogenosis mechanisms. So the issue is that the acid maltase deficiency, it is an autosomal recessive disorder, is a deficiency of liposomal enzyme that is called the acid maltase, which is also known as 1,4-glucosidase deficiency. In this condition, the patient might be having a several episode. It could be an infantile one, it could be a childhood form, it could be an adult form. Whenever you think about the infantile episode, there could be, accumulation of glycogen in a lot of cases. So there could be feeding difficulty, there could be hepatosplenomegaly, so there could be hepatomegaly as the glycogen will be stored in the liver, so it will be accumulated there. It will be cardiomegaly with macroglossia. So these are the Pompe's in the infantile form. In case of child form, on the other hand, the muscle involvement will be there, the hypotonia will be there, cardiomegaly, hepatomegaly will be certainly involvement, but the issue is that the patient will die of pulmonary infection and respiratory failure because there could be association with respiratory failure. And in adult form, that will involve the 2nd to 4th decade. The patient will also having the proximal myopathy. Also, there will be weakness of the diaphragm causing type 2 respiratory failure. In adult form of the Pompe's disease, patient will not be having any cardiomegaly, hepatomegaly, or dysfunction. Okay. So the next question. A 29-year-old man having a history of slowly declining the exercise tolerance over the past year. The patient is currently ICU, intubated for respiratory failure, having the upper respiratory infection. The adult form of the acid maltase deficiency by adult Pompe's has been suspected. So issue is that giving the age of onset, so correct information I need to choose. So giving the age of onset and lack of cardiac and liver involvement, the patient, so as I told earlier, the patient having infantile onset, the young onset or adult onset. In adult onset, there should not be any cardiac or liver involvement. Okay, so there could be acid maltase deficiency in adult onset also. The muscle biopsy shows the vacuolated sarcoplasm with glycogen accumulation that stains strongly with acid phosphatase. Okay, this is not type 2, it's type 2 glycogenosis. It is an autosomal recessive condition. Mental retardation is, I'm not sure about this condition as well. So the issue is that whenever check the biopsy, you can check the vacuolated sarcoplasm. Huh? There could be, yes, there could be vacuolated sarcoplasm that stains strongly with the acid phosphatase. Okay, so that could be the issue there. So let's recapitulate. Acid maltase or glycogenesis type 2, it's autosomal recessive. Acid maltase deficiency will be there, or on the other hand, we can say it alpha 1 for glucosidase. This enzyme participate in the breakdown from glycogen to glucose. As the enzyme deficiency, glycogen will be accumulated in a lot of aspects, particularly in the young age. So young age, there could be macroglossia, there could be cyanosis, there could be hepatomegaly, there could be cardiomyopathy. In the childhood form, also there could be associated hepatomegaly, cardiomyopathy, having endless coughs, having pulmonary infection, having type respiratory failure. But the adult form, particularly more important, patient will be having proximal weakness and having weakness of the diaphragm, leading to neuromuscular respiratory failure. Now, the next question, consultation will be requested for a 6-month-old boy in the neonatal period required prolonged ventilation, tracheostomy, percutaneous gastrostomy insertion. On examination, he has bilateral ptosis, restricted eye movement, pupils are equal, react briskly to light. His mother is healthy, no evidence of neuromuscular disorder. On administration of edrophonium, the ptosis improved, sucking is stronger, eye movement improved. Okay, so whenever thinking about this is likely, the young age possibility. So botulinum could not be a possibility here, as there is, there is no temporal history compatible with that. Mitochondrial illness. The one thing is very important. The patient, after giving the edrophonium, the patient ptosis improved. So there could be two possibilities. It could be transient neonatal myasthenia. It is, following the delivery, whenever the mother is having the myasthenia gravis, the baby can have, transient myasthenic symptom. Another important thing is that there could be congenital acetylcholine receptor deficiency, or it could be congenital acetylcholine esterase deficiency. So whenever you give the edrophonium, the patient's condition improve. That is indicative of we are giving the patient, the edrophonium. Okay. So whenever, what is edrophonium? It is acetylcholine esterase inhibitor, right? Sorry, just a couple of minutes. Okay, let's continue. So what will be the diagnosis? I guess it is most likely in between the congenital acetylcholine receptor deficiency or esterase deficiency. So I'm going to talk it more about it later. So it is receptor deficiency. The patient history and clinical examination, most important, that is congenital myasthenia due to receptor deficiency. It is a congenital myasthenic syndrome. In case of congenital myasthenic syndrome, typically a heterogeneous group of neuromuscular junction disorder. They more commonly present in the time of birth, but usually not present in the childhood or adulthood. Okay, typical presentation is in the infancy there will be ophthalmoplegia, or there will be ptosis, there will be facial diaparesis. Okay, limb weakness, hypotonia could be present, but respiratory involvement is typically rare. So in case of autoimmune myasthenia gravis or some form of congenital myasthenia, intravenous administration of edrophonium is typically improving the symptom. Okay, and the benefit is from the acetylcholine esterase inhibitor as well, because the congenital myasthenic symptom is not immunomediated. So there is no response to immunosuppressive or thymectomy. You should remember the fact. Okay, it is due to the enzyme deficiency or receptor deficiency. So whenever we are going to check, the electrophysiological findings, okay, the electrophysiological findings can have sometimes can have a detrimental response on repeated nerve stimulation or increased jitter in single fiber EMG. The most common form of congenital myasthenia, you should remember, it is the receptor deficiency. Okay, so receptor deficiency, it is due to autosomal recessive, it is due to sporadic mutation that could be associated. The acetylcholine esterase deficiency is another congenital myasthenic syndrome that can present with axial respi weakness. Typically, the patient having delayed response. So there could be sometimes delayed pupillary response to right as well. So as there is no issues of light response, okay, due to deficiency of enzyme, this patient do not respond to as there is the enzyme is not there, okay, so how much the enzyme is what I'm going to inhibit, right? So the issue is it is due to receptor deficiency. So receptor is there's some scarcity of receptor. You will give the acetylcholinesterase inhibitor, so enzyme will be inhibited. There could be a benefit. But issue is that when there is no enzyme, so there could be no response, right? The newborn mother with myasthenia gravis, transient myasthenic syndrome can occur due to transfer of maternal antibody to the fetus in utero. The signs of neonatal myasthenia can have the hypotonia, can have poor feeding, can have antibody to the fetus in the utero. Signs of neonatal myasthenia include the hypotonia and poor feeding. Okay, the symptoms improving typically within 2 weeks of life. The patient will come with myasthenic syndrome in the first place, but we should remember the symptom will typically improve in the first 2 weeks of life. Okay, the patient sign symptom in this condition is 6 months, so there's absence of the history of myasthenia gravis in case of mother, so that is lesser possibility. Okay. Other disorder can lead to ophthalmoparesis or ptosis, that could be mitochondrial disease, that could be botulism, but fluctuating response, fluctuating weakness and good response to atrophonium, the other possibility a bit lesser, right? For a 14-year-old boy complaining progressive weakness in the shoulder and upper arm with mild involvement of the lower extremities. So there's shoulder weakness, upper arm weakness, there's significant contracture, no pseudohypertrophy. The ECG is often due to bradycardic involvement. There's AV block. So there is cardiac involvement. There is scapulohumeral, peroneal is not that much here. Okay. And there is contracture. So conduction, contracture, scapulohumeral involvement. It is Emery Rufus. Okay. So whenever thinking Emery Rufus, there is a mutation of several genes in the symptom. There could be autosomal dominant form that will lamine SC, that will involve the gene LMNA. Okay, and in case of Emery Rufus muscular dystrophy, typically presents with contracture. They can have contracture involving the elbow, ankle, and the neck. The muscle weakness, particularly there could be shoulder weakness, there could be arms weakness, there could be peroneal weakness. There's no pseudohypertrophy. The IQ is absolutely normal, but the issue is that there's serious cardiac conduction abnormality. Might be requiring pacemaker in the long run. So I guess it is more in favor of Emery Rufus. The issue is there, the problem, it could be Emerin and laminacy. So AB will be the answer. Dystrophin is not there. So I guess it is Emerin and laminacy. I'm marking those two options. So an infant is diagnosed with congenital muscular dystrophy. He's weak, multiple contracture, distal hyperlaxity. As I told earlier, in order to diagnose a case, we should check about the congenital muscular dystrophy. There's a lot of condition, right? There could be collagenopathies. In collagenopathies, there's two important diagnoses. One is Bethlehem. Another important thing is early congenital muscular dystrophy. Whenever I want to diagnose a case of early congenital muscular dystrophy, in a young patient might be having contracture with distal hyperlaxity. There could be prominent protrusion of the calcaneus also. So it could be Ehrlich's muscular dystrophy, right? So it could be the most important possibility. The patient might be having Ehrlich muscular dystrophy, which is a collagenopathy, problem of the type 6 collagen. Okay. Sometimes type 6 collagen could be involved in the Bethlehem myopathy also. But the issue is that whenever we are thinking of Bethlehem myopathy, the patient will be having some weakness contracture. The issue is that there could be hyperextensible interphalangeal joint. Okay. This is the merosenopathy. They are involving the laminin 1 alpha 2 involvement. The patient will be having also their typical hypotonia with contracture, but the patient is having, normal extraocular muscle, normal ptosis. There will be no ptosis. There will be normal IQ. So this is important. So another possibility, the three important disorder, they are the dystroglycanopathies. They are the, the Walker-Warburg syndrome, muscle hybrid disease, and Fukuoka type congenital dystrophy, right? So we should remember this fact as well. Issue is that whenever you're thinking about the Walker-Warburg syndrome, it is a condition of muscle dystrophy. There is some brain involvement. There's some eye involvement as well. But the issue is that eye involvement will be a wide spread. Like there could be microphthalmia, the less eye involvement, there will be cobbloma, there will be cataract, there will be glaucoma. Okay, there will be corneal opacity as well. Optic atrophy can also be there. There should be, hydrocephalus. There could be cerebral hypoplasia. So these are a lot of cortical issues will be also present. In the muscular brain disease, there could be also some muscular dystrophy alongside with the brain and ocular involvement as well. Okay, we should remember this fact. Just a couple of minutes. So whenever we talk, we have discussed about the lissencephaly. Okay, so type 2 lissencephaly, that was the cobblestone lissencephaly. These are some types. In that condition, the Walker-Warburg or Fukuoka, this could be some possibility, or something called the muscular brain disease. Okay, so type 2 lissencephaly. So now some issues regarding the sympathetic or parasympathetic issue. So whenever you think about the anatomy of the sympathetic parasympathetic nervous system, the parasympathetic, we should know some facts. Okay, whenever the parasympathetic post, so I need to check the correct option as well. So the parasympathetic postganglionic neuron typically released the norepinephrine. So we need to check the correct option. Cell body of the neuron provide innervation to detrusor muscle of the bladder. It is L2 to L4. Intermediolateral T1 to L2. I guess it is wrong. So I'm marking it as red. Gray rami communicants carry the preganglionic fiber. White rami communicant carry the postganglionic fiber. The parasympathetic ganglia located close to the end organ. Okay. Whereas the sympathetic ganglion are distal from the end organ. Sympathetic postganglionic longer compared to parasympathetic postganglionic. Okay, that's a very good thing. The issue is that first of all, the parasympathetic postganglion doesn't certainly release the norepinephrine. That is wrong. So I'm going to cut it also. Okay, cell body of the neuron, this is also certainly wrong. The gray rami also wrong. So E will be the most common answer. So whenever we're thinking about, the sympathetic and parasympathetic, the function, the sympathetic, parasympathetic, that's mainly deal with the craniosacral outflow. There will be 4 cranial nerve like 3, 7, 9, and 10. And particularly another important fiber, they came from the sacral 2, 3, and 4. Particularly the parasympathetic having, long preganglionic with short postganglionic fiber. Okay. So whenever the cell located in the S2 to S4, they give rise to the sacral portion of the spinal parasympathetic nervous system, innervate the genitourinary system and distal part of the colon. Okay, the neurotransmitter for all sympathetic and parasympathetic fiber. You should remember, the issue is that the neurotransmitter for all sympathetic and parasympathetic, in particularly, they release the the acetylcholine in the most cases. Okay, so parasympathetic preganglionic acetylcholine, parasympathetic postganglionic also acetylcholine. Okay, so parasympathetic function, there's some parasympathetic function. I'm not going to talk about that. Only I'll talk about the erection, because parasympathetic is erection, sympathetic is ejaculation. Okay. Now, issue is that intermediolateral gray column that involving the T1 to L2, that containing the preganglionic neuron of the sympathetic nervous system. They're small myelinated preganglionic with very long, postganglionic fiber. The small myelinated preganglionic, they are the white rami communicants, as because they exit from the intermedial lateral gray column, okay, and synapse and the sympathetic ganglia in the paravertebral region. So gray white rami communicant, they are quite a smaller fiber. On the other hand, the gray rami communicant, they are tends to carry the spinal nerve from the T1 to T4 from the thoracic, supply the thoracic region, or T5 to L2 supply the subdiaphragmatic region as well. So very important. So issue is that the gray rami is you should remember the fact. So this is the thing I'm going to the small myelinated, the preganglionic is white rami. White rami actually exit from the intermediolateral cell column and synapse in the sympathetic ganglia, and the gray rami communicant is particularly involving the other part, the supplying the typical viscera. From T1 to T4, it's involving the superior thoracic region. From T5 to L2, it involves the subdiaphragmatic region as well. Okay, so issue is that the parasympathetic is acetylcholine, sympathetic, preganglionic, acetylcholine, sympathetic, postganglionic, norepinephrine, except the sweat gland. Okay, in case of sweat gland, where the acetylcholine, it will be the typical fiber. This is the typical scenario. Okay, let it go. Now, issue is that this is an important question here. A 62 years old woman patient with diabetes who has smoked since her teenage, I guess, being evaluated for her annual examination. She has been doing relatively well, except for a chronic cough, attributes to smoking. On a few days ago, she fell a few days ago, but didn't hit her head. On examination, the physician noticed that his left eyelid is droopy. There is some, the left pupil is also smaller, so there is corner. The left face appear less moist compared to right, so there could be a Horner syndrome, right? So there will be ptosis, meiosis, and anhidrosis as well. So it is I could effectively exclude the patient having a internal carotid dissection. So the patient won't be having any sympathetic involvement in the sweat fiber will be spared in this condition because it goes with the external carotid region. So it's wrong. Second thing is that oculomotor palsy cannot be explained. Ptosis not be there. So I think it could be apical landmass causing Horner's. That could be the very important possibilities. The issue is that Horner syndrome can be having any issue regarding the sympathetic pathway. Particularly the sympathetic pathway can originate from the hypothalamus. They goes to the the spinal area of bulge. Okay, that will the typical sympathetic neuron in the intermedial lateral cell column. Okay, after that the senio is spinic area bulge. This is the CA to T2. This is the area from where our face is going to take the supply. Okay, so from CA to T2, this fiber synapse particularly in the superior cervical ganglion. The postganglion fiber travel around the common carotid artery. After the bifurcation of the common carotid, there is sometimes the sphincter pupillae, the fiber carries with the internal carotid artery. So whenever if you are going to involve the intercarotid dissection or having a cavernous sinus lesion, the pupillary pipe or cluster headache, the sweat fiber will be unaffected. Okay, the issue is that because the sympathetic fiber designated to sweat gland, particularly eccrine gland, that travel along with the external carotid artery. So Horner syndrome or oculosympathetic paresis, they're having the lesion the sympathetic pathway. Okay, we are having some other session for that as well. We are getting the patient with ptosis, meiosis, anhidrosis. Enophthalmos will be there because upper eyelid will be droopy, lower eyelid will be a bit elevated. Okay, so there could be apparent enophthalmos. These are the important features we should remember. So lesion in the left and the internal carotid artery dissection, they will spare the sweat fiber because sweat fiber will be with the equine part of the face, so anhidrosis won't be occur. So this is typical Horner syndrome. The typical presentation, because the patient is smoking, having cough, so there could be a Pentecost. They can easily compress the sympathetic fiber as well. Sometimes they can involve the lower trunk of brachial plexus, even involving the wasting of the hand muscle also. Okay. Okay, well, whenever we want to diagnose a Horner syndrome, we can give the patient some drug, particularly the cocaine. They can have some role. Levator disease is a common cause of ptosis in the older age, but the pupillary involvement and other features of Horner will not be occurring in this scenario. So this is another question. A 42 years old man involved in motor vehicle accident. He experiences right-sided neck pain, also having drooping of the eyelid, pupil is smaller, and right eye shrunken. Carotid, there is some carotid dissection. Which one of the following will be correct? First of all, there will be anhidrosis wrong. Iris is droopy due to involvement of levator palpebrally. No, it is due to third nerve palsy. There could be involvement of molar muscle causing droopy eyelid. The eyelid abnormality result from extension of dissection to cavernous sinus. Involvement of, I don't think so. Anisocoria will become more apparent in dim light. That could be a possibility. I guess whenever you try to have whenever it's exposed to dim light or dark light, there will be pupillary dilatation. Okay, so whenever a person exposed to dark light, the normal people will dilate, the Horner people will be constricted. So the anisocoria will be much more pronounced. Okay. Which one of the following is not a distal muscular dystrophy? The Myoshi, the Nonaka, the Wallender, they all are distal myopathy. There's without any doubt. The type 1 is also, the type 2 is the proximal. The type 2 dystrophica myotonia is a proximal myopathy, and distal myopathy are the group of disorder that shows a progressive with most commonly affecting the adult life, though earlier presentation can occur. So there's some weakness and atrophy of the distal muscle of the hands, forearms, and legs. Some are autosomal dominant, some are autosomal recessive. Because dystrophic myotonia type 1 is autosomal dominant, Wallender is also Wallender is also dominant, but Nonaka and I guess it's recessive. Okay, Nonaka and Myoshi is typically recessive. So, particularly important fact, the Myoshi, as I told earlier, the early adulthood, it is a dysphrenulopathy associated with limb-girdle myopathy type 2B. It's a recessive. Nonaka is also recessive. The patient might be having a typical venereal-like inclusion body myositis. It is also recessive. On the other hand, the Wallender, the scapuloperoneal, the Desmin, the Liang, the Marcus-Borey creeks, these are the autosomal dominant. So it's so peculiar, right? Okay, I'm giving another break for about 2 minutes, then we'll continue again. Sorry for the interruption once again. I'm going to resume the session for the last 20 minutes. Okay, so the following statement is incorrect regarding the intervention of the genitourinary system. First of all, whenever we are thinking about the genitourinary complaint, like there is intermediate cell column of the spinal cord at the level of the L1, L2 provides sympathetic innervation to the bladder. It's not okay. Okay, that could be a possibility. The sympathetic innervation comes from the L1, L2, nerve root from the S2, S3, S4. They can have relay afferent sensory information from the genitourinary system, bladder, anorectal area. Okay, the on-off nucleus contains the cell body of the neuron that control the urethral and anal sphincter. Okay, the somatic efferents to the skeletal muscle of the pelvic floor arises from the pudendal nerve S2 to S4, and penile erection is mediated by sympathetic ejaculation. This absolutely last option will be the answer, because the erection will be parasympathetic and ejaculation will be of sympathetic. So penile erection is mediated by the parasympathetic nervous system and ejaculation is by the sympathetic nervous system. In detrusor sphincter dyssynergia, the detrusor muscle contracts against a unrelaxed sphincter, because the problem is that, as you can see, suppose this is a bladder, this is the ultimate sphincter. In this condition, the sphincter is constricted. Okay, it is absolutely constricted, but the bladder is contracting. This is contracting, and the sphincter is also contracting. The issue is that whenever the sphincter, whenever a bladder is contracting, there will be the urination. The sphincter must be relaxed. Okay, but the issue is that this is a peculiar condition. The muscle is contracting against an unrelaxed urethral sphincter, because the internal urethral sphincter is under the sympathetic control. Okay, so internal sphincter, always we should remember the internal sphincter is always under the sympathetic control. Okay, whenever we try to know the further about the micturition center have some voluntary and involuntary components. The voluntary component of the So the micturition center has some voluntary and involuntary components, as I discussed earlier. The voluntary contraction could be mediated by the external urethral sphincter. The external urethral sphincter could be mediated by the, that will be typically involving the pudendal nerve. It's wrong information given here. Okay, so there's, in case of micturition, in a nutshell, if we understand the bladder, so if this is a bladder, okay, so if this is urogenital diaphragm, so this is typical the external sphincter. Okay, so this is the internal sphincter. Okay, so the internal sphincter is typically involving the L1, L2. It's from the spinal cord. This is the sympathetic stimulation. The external sphincter will be the voluntary control. They will be from the pudendal nerve, I guess. So that is very important. Okay, so if we go there, first of all, important thing is that the intermedial lateral cell cord of the spinal cord at the level of the L1, L2, they can give the sympathetic innervation. They can give the sympathetic innervation to the bladder, but the inflammation will be given to the actually the internal sphincter. Okay, the external sphincter is the pudendal nerve, that is a somatic. Okay, so this is the somatic. It arises from the pelvic. It arises from the anterior horn cell. It supplies the muscle of the pelvic floor. Okay, so on-off nucleus is the parasympathetic nucleus. They can supply particularly to the sphincter and also the bladder wall. This is the parasympathetic nucleus as well. So whenever the micturition has both voluntary and involuntary part. The voluntary part is typically controlled by the external urethral sphincter, which is under pudendal nerve control, and the involuntary part will be mediated by two important functions. First of all, one of things that will be increases the possibility of micturition, that is the sympathetic, that is the parasympathetic, and sympathetic will try to hold urine upon the response from the spinal cord, right? This is the important part. So there could be parasympathetic nerve root. There is the on-off nucleus from the S2 to S4. That is typically involving the urethral and anal sphincter. Normally, in normal condition, the individuals will be able to maintain the voluntary control of the micturition through the medial frontal center. That is the medial frontal micturition center in the paracentral lobule. I guess this is the the frontal micturition center. This is inhibit the possibility of decrease the possibility of having any micturition whenever it is not ideal to do so. Okay, so at the initiation of the voluntary micturition, the detrusor reflex that is mediated by the spinal cord circuit, in that moment, there will be inhibition of the external urethral sphincter, which is via the pudendal nerve. And second thing is that involuntary relaxation of the internal urethral sphincter, which is via the sympathetic, which is normally supplied by the sympathetic nerve as well. Okay, so urinary incontinence can have a lot of condition regarding that, particularly whether if there is any involvement of the sacral fibers. Okay, the cord iconius syndrome, at that moment there could be lower motor type of injury. So at that time, bladder will flaccid with having overflow incontinence with post micturition dribbling. A lot of urine will be written there. At that time, it's better to do a self catheterization. Sometimes if there is any lesion in the frontal lobe, they having the voluntary control is absolutely lost. At that time, the patient will having a flaccid bladder with overflow incontinence. Sometimes there could be urination here there. Okay, that could be a possibility also. Arch, if there is their conus medullaris lesion or any lesion in the spinal cord, particularly in the arch continence, at that time there is overactive detrusor contraction will be mediated by parasympathetic nerve. It could be occurred during the any demyelinating disorder or any abnormality in the spinal cord as well. Sometimes there could be arch incontinence, there could be overactive bladder, and there could be urination. Okay. So penile erection, as I told earlier, erection will be parasympathetic, mediated by S3, S4 via the pudendal nerve, and ejaculation is typically sympathetic via the dorsal nerve of the penis. Okay. So issue is that point and shoot, parasympathetic is erection, shoot, sympathetic is the ejaculation. How good. Now, the next information, considering, let's solve this question. Which one of the following pairs of urinary symptoms associated with bladder abnormality are incorrect? Okay, so we need to check the incorrect. A 62 years old man, Corda equina syndrome, involuntary urinates when a pressure applied to the bladder. It is flaccid and reflexive bladder leading to overflow incontinence. Absolutely correct, because this is the lower motor. So bladder will be flaccid. So there will be a lot of urination. A lot of urine will be accumulated in the bladder. The bladder will be, overflowed with urine. Whenever you make some compress, there will be some dribbling of the urination. So this is absolutely true. 72 years old with normal pressure hydrocephalus who has no control over urination, dysfunction of the medial frontal micturition center of the paracentral lobule, leading to voluntary suppression of the detrusor reflex. Okay, so whenever we want to, we can hold our urination, this is due to our frontal micturition center. We can, have the ability. Whatever the frontal micturition center, particularly the frontal paracentral lobule is damaged, at that moment the issue is gone. Particularly in a lot of conditions like frontal lobe tumor or normal hydrocephalus, they can have it. This is also true. A 17 years old boy who has sustained a thoracic cord contusion 2 days ago, unable to urinate. Okay, atonic bladder with leafless contraction of urethral sphincter leading to urinary retention. Okay, there is thoracic cord contraction. Whenever the patient having thoracic cord contusion 2 days ago, unable to urinate, is an atonic bladder. So whenever the patient having thoracic cord contusion, there could be a possibility of having spinal injury. Okay, they can have urinary retention as well, I guess. The MS. Next question has a patient with multiple sclerosis who has multiple spinal cord lesion, having incontinence because he senses the need to urinate, but such urgency she cannot be able to make it to the bathroom in time. I guess the patient that is overactive bladder in this condition, the overactive bladder, there will be urge incontinence. So whenever he try to need to go to urine, there will be urination. So it is not detrusor hyper. It is actually Yes, detrusor hyperreflexia could be a possibility. So it is also another possibility. A 54 years old man, multiple sclerosis, having a severe painful pelvic cramp associated with sensation, that she needs to urinate, but after urination, she feels that was not voided completely. Detrusor sphincter dyssynergia resulting from a contraction of the, I guess E will be the answer. Okay, in the detrusor sphincter dyssynergia, the detrusor muscle contracts against a unrelaxed urethral sphincter. So in that moment, there will be, there will be extreme urination difficulty. There will be urge of urination, and there will be severe painful micturition because the bladder is contracting, but internal sphincter is not relaxed. It's not like that I'm going to urinate after urination. I need to have, it's something like that. It's an incomplete evacuation. So it is more in favor of, whenever we think about incomplete evacuation, this is more stress incontinence could be a possibility. Okay. Next question. There's a misinformation given in this scenario, so I'm not going to read the scenario. Later I will be talking about a further regarding our micturition center and other issue. I'll give a short video regarding that. So regarding the bladder function, which one of the following statements are correct? Normally there will be voluntary inhibition of the detrusor reflex by medial frontal micturition center in the paracentral lobule. This is absolutely true. This is the frontal micturition center. We can control the micturition by means of that. External urethral sphincter is under voluntary control. True. Internal sphincter is under sympathetic control. That is false. So C will be the answer. Micturition center is located in the pons that regulate the detrusor reflex. True. In the detrusor sphincter dyssynergia, detrusor muscle contracting and an unrelaxed urethral sphincter. True. So it will be the C will be most appropriate answer as well. So that's it from today's session. In the next session, we'll come again for a next topic. So till now, thank you so much. It's a goodbye.